Neuroscience and Psychiatry, for inviting me to participate in it. It is a tremendous honor for me to share the results of the research, Parkinson among early signal detection of motor disorders with statins. My name is María Isabel Jiménez Sorania, and I am an associate professor at the Miguel de Cervantes European University from Valladolid, Spain. As a brief introduction to myself, I'm a pharmacist, biochemist, and doctor of pharmacy from the University of Salamanca, Spain. I'm a professor of pharmacology, physiology, and biochemistry, and I do research in the field of pharmacovigilance, pharmacoepidemiology, and pharmacogenetics. As a starting point, statins are 3-hydroxy-3-methylglutaryl coenzyme A reductase inhibitors and are active ingredients capable of blocking the endogenous synthesis of cholesterol in the critical and limiting step of mevalonic acid production, with the intention to reduce the high levels of LDL cholesterol in blood. They are prescribed for hypercholesterolemia with or without hypertriglyceridemia. These drugs are considered safe and cost-effective. The safety of these drugs has been studied and followed up over time. The low occurrence of severe adverse events, e.g. rhabdomyolysis and increased transaminases, and widespread use lead to a relaxation in the observation and prevention of other events, less frequent or severe but the quality of life of patient. We must consider that one of the former statins, rosuvastatin, was withdrawn due to an adverse drug reaction classified as rare, such as rhabdomyolysis, with potential lead to kidney failure. So it could be interesting to get inside potential rare or very rare ADRs with statins, stated or not stated in fascists. Most adverse reactions with statins reported in summary of product characteristics as rare or very rare are associated with blood, gastrointestinal disorders, hepatobiliary disorders, immune system disorders, musculoskeletal and connective tissue disorders, nervous system, skin and subcutaneous disorders, reproductive systems and breast disorders, sense disorders, or general disorders. But as of extralipidemic or pleiotropic effects of statins are less studied, neither are the ADR related to them. Surprisingly, no one motor disorders appears as ADR in species. Due to this situation, the objective of this research is to provide an early knowledge of signals of statins adverse reactions, especially related to motor disorders, with the intention to offer a list of candidates of per-statin motor ADRs to analyze in future trials. Getting inside the material and methods of this research. Nowadays, free access to national and international reporting ADR databases allows investigating new signals to be aware of possible risks. One of them is VG-Base, the unique World Health Organization global database for suspected ADRs maintained by the Uppsala Monitoring Center since 1968. This database disposes of free user interface VG Access that allows to search all data coming from over 110 countries, undersinging a statement of the responsibility for the appropriate use and interpretation of data. For the present study, reported data of all ADR related to the chemical subgroup of the Anatomical Therapeutic Chemical Classification System, C10AA, known as statins, were searched in VG Access. Data below the first heading ADR for each active ingredient, atorvastatin, ferivastatin, fluvastatin, lovastatin, pravastatin, rosuvastatin, simvastatin, and pitavastatin were extracted. Signals for ferivastatin are included and analyzed as of contrast. In this database, it is not possible to calculate the frequency of any ADR, but the data mining methodology Bayesian Confidence Propagation Neural Network (BCPNN) can be used in these situations. Nevertheless, this methodology is developed and used by the UMC as the World Health Organization Collaborating Center for International Drug Monitoring. To detect signals of ADR, this method, BCPNN, was improved by the UMC with an extension of the multiple comparison setting. The calculated Bayesian estimator of false discovery rate, FDR, works like a p-value, offering a positive signal if FDR is less than 0.05. An adaptation of this methodology can be plausible as some as other reverse methods can be trustworthy in global adverse drug reaction surveillance with a correct interpretation of the signals. This one consists of contrasting all the ADR of the 86 subgroups instead of all pairs ADR drugs of the database. In this case, only the chemical subgroup C10AA was considered into the analysis. This methodology approach was previously demonstrated robustness and consistency when instead of all ADR databases were applied to a specific group of drugs, such as anticoagulants, antidiabetics, or COVID-19 vaccines. You can see here details of the algorithm performed, but in essence, the estimator of FDR less than 0.05 and specificity greater than or equal to 0.99 are considered to interpret the results. All positive signals among statins were obtained. Those related to motor disorders were extracted, grouped depending on the presence of the ADR in the summary of product characteristics of each active ingredient implied, and categorized according to high-level terms, HLT, including preferred terms, PT, of the Medical Dictionary of Regulatory Activities, MIDRA, the standard methodology used in VG Access. The first aggregation of statin-positive signals obtained was related to similar pathology following MIDRA obtaining the sets of ataxia, Parkinson, movement disorders, and other symptoms related to motor disorders conditions. Finally, a ranking of positive signals for each statin is proposed as a list of priority ADR for further study. The R-free software and the PHBD package were used to implement the methodology and to obtain positive signals. All searches of evidence were made in the Medline database via PubMed. Let's go to the results. The total of positive signals was 493, being 21 out of them related to a motor disorder, and as you can see, the highest value belongs to simvastatin with more than 30% of the signals. The first set analyzed was ataxia. You can see that all of signals were not stated in SPCs, including ataxia or cerebellar ataxia. And for all of them, simvastatin and cerebellar ataxia is the signal that offers a sensitivity more than 0.20. Digging deeper into the results, in the preliminary analysis, simvastatin is the only one that showed a positive signal of cerebral ataxia and elevated numbers for general ataxia, following the distance by lovastatin and fluvastatin that presents only signals for general ataxia. These two last ones can be used as a control in studies to differentiate general ataxia from cerebral ataxia for statins. The rest of statins do not appear to generate situations related to ataxia, a fact to consider in the prescription of patients with a risk of this condition. CoQ10 is an antioxidant component of oxidative phosphorylation in mitochondria. Due to farnesyl pyrophosphate being a critical intermediate for CoQ10 synthesis, blockage of this step by statins may be important in the occurrence of myopathy and also have been associated with encephalomyopathy, severe infantile multisystemic disease, cerebral ataxia, nephrotic syndrome, and isolated myopathy. These are case series of patients with cerebral ataxia due to statins use, which the authors consider probably related to CoQ10 deficiency, but exposures to CoQ10, statins, and vitamin E did not appear to influence the clinical progression of spinocerebellar ataxia within 2 years. The second set analyzed was Parkinson, including Parkinsonism and Parkinson's disease, all of them not stated in SPCs. There are clear positive signals with enough sensitivity for simvastatin and pitavastatin related to Parkinsonism, unless some elevated figures for pairs drug ADR for atorvastatin and rosuvastatin presents signals with weak sensitivity for Parkinson's disease. In the preliminary analysis, the statins more related to Parkinsonism were simvastatin and pitavastatin, and Parkinson's disease were atorvastatin and rosuvastatin. Due to the plasma 24-hydroxyl-cholesterol seems inversely linked to Parkinson's disease, it could lead to those higher levels of total and LDL cholesterol over time, indicating a decreased Parkinson risk. The use of lipophilic statins, such as simvastatin, lovastatin, atorvastatin, fluvastatin, and pitavastatin, was associated with a higher risk of Parkinson, and the stronger association in initial use suggests a facilitating effect. But the effect in long-term studies fades as the evidence of their benefit in Parkinsonism. But hydrophobicity is a key determinant for blood-brain barrier penetrance, and this recently suggests that hydrophobic but not lipophilic statins may be associated with faster Parkinson progression. The authors of a recent publication also considered that statins use may have a detrimental effect on baseline neurostriatal dopamine generation and long-term outcomes in patients with Parkinson's disease. There is a randomized controlled trial, PD-STATS, for simvastatin as a neuroprotective treatment for Parkinson. The study clearly showed that simvastatin, in comparison with placebo, is unlikely to slow the rate of progression of Parkinson's disease, and further trials of simvastatin as a protective therapy in Parkinson's should not be recommended. There were no safety concerns with the use of simvastatin. Although the results of the PD-STATS trial did not show that simvastatin was promised as a protective therapy in Parkinson's, it is a great achievement to have a definitive answer to this important question. The reality is that in patients with Parkinson, statins are less used without clear evidence. In a study, it was observed that over 60% of recent-onset Parkinson's disease patients have high or medium cardiovascular risk, which is associated with a worse motor and cognitive phenotype, but statins are underused in these patients. The third set analyzed was movement disorders, including eye movement disorders. Again, all signals are not stated in fascists. Moreover, simvastatin saw in the past 90 cases related to movement disorders. An exclusive eye movement disorders with pravastatin was identified with enough sensitivity. There is evidence of movement disorders that appears as ADR due to a delay in the diagnosis of patients with Huntington's disease with premotor symptoms or Parkinson's disease. Concerning general movement disorders, it is difficult to extract conclusions for former studies, but now statins seems to be protective. About eye movement disorders, perhaps this ADR could be used as an alarm for surrounding movement disorders not diagnosed. Additionally, all statins, except pravastatin, are metabolized by the CYP40-150, and drugs that induce or inhibit CYPs can alter statins levels. Pravastatin is eliminated virtually unchanged by phase II reactions, conjugation, or increased water solubility. This situation leads to underdose or overdose of other statins. It is well recognized that statins affect muscle tissue adversely, but at the same time these agents may act as unmasking agents in asymptomatic patients with a latent neuromuscular disorder. Muscular symptoms or increased serum CK levels persisting after statin treatment discontinuation should alert the clinician to pursue further diagnostic evaluation for the detection of potential underlying neuromuscular disease. The fourth set analyzed was other symptoms related to motor disorders also not stated in SPCs. Regarding to other positive signals related to motor disorders observed, akathisia, echinacea, cogwheel rigidity, joint stiffness, musculoskeletal stiffness, muscle rigidity, fatigue, and tremor. The signals with more sensitivity in the analysis were akathisia with simvastatin, muscle rigidity with pravastatin, and signals of musculoskeletal stiffness and tremor for the more recent included pitavastatin. Fatigue has less sensitivity but is reported in more than 2,000 pairs with simvastatin. Fluvastatin and lovastatin are free of all these signals and can be candidates for the statin interchange. But is there a plausible relationship for this set of signals? Some of these symptoms are shared with other comorbidities as rheumatoid arthritis. There is evidence of the pleiotropic effects of statins on ameliorating rheumatoid arthritis activity and mediating clinically apparent anti-inflammatory effects in related autoimmune inflammation, which leads the authors to recommend statins as a potent treatment for these patients. Other investigators have established that association between statin use and poor physical functioning and self-rated health may be explained by factors other than joint pain or stiffness, e.g. muscle pain. So the affectation of statins in these other motor symptoms could be complicated to differentiate from the known effect of myalgia by statins used rather than the real appearance of these conditions. This deduction could be plausible with respect to akathisia, echinacea, cogwheel rigidity, joint stiffness, muscle rigidity, and musculoskeletal stiffness, but less simple to understand the relationship between fatigue and tremor. At the same time, there is no evidence that statins use was protective in essential tremor. As a summary, due to the scarcity of strong evidence, it is relevant to propose a list of positive signals not stated in the fact sheets for each active ingredient and motor disorders with high sensitivity, such as pitavastatin and Parkinsonins, or musculoskeletal stiffness or tremor, pravastatin and eye movement disorders or muscle rigidity, and simvastatin and cerebellar ataxia or Parkinsonins or akathisia. Also, it could be necessary to pay attention in terms of number of reports to two signals, unless a low sensitivity, atorvastatin or rosuvastatin, seems related to Parkinson's disease. In conclusion, according with the pleiotropic effect discussed, serial motor signals detected with higher sensitivity are proposed to further investigation. Out of them, Parkinsonism related to pitavastatin and simvastatin. As a reference to statin interchange in case of detecting any early motor ADRs, and due to the low positive motor signals detected, fluvastatin and lovastatin were considered as the safer candidates. I hope that the results presented will be useful.
Conducted with Professor Yehuda Pollack and Professor Ilan Yaniv from the Hebrew University. Our study explores the relationship between ADHD and soft drug use. What drives soft drug use in ADHD? Insensitivity to risk or enthusiasm for benefit? ADHD is a neurodevelopmental disorder with a global prevalence of approximately 5.3 in childhood and 70% of these cases persist into adulthood. Clinical evidence links ADHD to long-term functional impairments across academic, social, and occupational domains, as well as negative health outcomes, including physical injury. ADHD has high prevalence of psychiatric comorbidities. Research consistently associated ADHD with increased involvement in risky behaviors. A meta-analysis of 23 prospective studies found that ADHD in childhood is a significant risk factor for later use of nicotine, alcohol, drugs, and substance use disorders, even when controlling for behavioral comorbidities. The MTA study follow-up supports these findings. Children with ADHD were younger than those in the control group when they used substance for the first time and showed greater use of marijuana and cigarette smoking as adults. A Swedish study revealed that ADHD diagnosis before age 15 significantly increases the risk of substance use disorders independent of stimulant treatment. This study adopts a behavioral economics framework to investigate the mechanisms underlying soft drug use in a clinical sample of adults with ADHD. In order to understand the differences between the clinical approach and that of behavioral economics, it is necessary to examine how each of the approaches defines risks and the involvement in risky behavior. The clinical approach examines the behavior. The clinical approach examines the behavior, meaning the focus is on the result, the outcome. Therefore, the definition of risk is behavior that may cause harm to oneself or others. On the other hand, the behavioral economics approach treats risky behavior as a choice, and hence the focus is on the decision maker. This approach defines risk-taking as a choice among options with a variety of outcomes, with both positive and negative potential outcomes. This distinction provides deeper insights into mechanisms behind risky behaviors and informs targeted interventions. This study applies a behavioral economics paradigm to explore behaviors traditionally examined through clinical frameworks, offering a novel perspective on decision-making and intervention strategies. The research question came to examine whether people with ADHD tend to use soft drugs because of the benefit or because of the insensitivity to risk. The measures of this research, in this research, we used DIVA to confirm or to rule out ADHD diagnosis, supplemented by reports from parents, spouses, siblings, or teachers. We used the SCID to screen for psychiatric disorders. We used the ASRS questionnaire to assess ADHD symptoms. And we also measure frequency and the likelihood of using soft drugs. We measured risk and benefit in two ways. In one, participants rated the risk and benefit attributed to the use of soft drugs based on their gut feelings. In the second, we used the psychometric paradigm in which participants rated 25 characteristics associated with risk, benefit, and general variables associated with involvement with soft drug use. I would like to explain more about the psychometric paradigm. Respondents were asked to evaluate their involvement in soft drug use based on 25 characteristics spanning risk, benefit, and general factors. For risk-related variables, they assessed aspects such as the perceived harm from soft drug use, including its severity, timing, and duration, the degree of knowledge about the harm, and the personal and community probability of harm. For benefit-related variables, they evaluated similar indicators such as the timing of the benefit's appearance, its duration, and the individual and population level probabilities of benefit. Additional benefit-related variables included the thrill, intensity of the benefit, alleviation of burden, anger management, and strong desire for the benefits associated with soft drug use. In addition, respondents addressed general factors associated with involvement in the activity, such as the accessibility of drugs, social pressure, conflicts with family values, the need for supervision on the matter, the necessity to hide their involvement from others, the time taken to make decisions, and the extent to which their past experiences influenced their decision to use drugs. The descriptive data reveals similarities between the ADHD and non-ADHD groups in sample size, gender, age, and socioeconomic status. Significant differences were seen in education with higher levels in the non-ADHD group. As expected, ADHD symptoms were more prevalent in the ADHD group, along with increased use of soft drugs among individuals with ADHD. Comorbidities were assessed across categories such as depression, past trauma and stress, anxiety, OCD, substance use, somatic symptoms, and eating disorders. Significant differences between the groups were consistent with the research literature in the categories of depression, past trauma and stress, substance use, and eating disorders. In addition, we checked the frequency of the use of soft drugs for all subjects. The findings were classified according to those who had never tried or used soft drugs, those who had just experimented, those who used soft drugs in the past but now no longer, and those who are currently using soft drugs. Significant differences can be seen for those who have never tried or used soft drugs, meaning that more individuals without ADHD had never tried soft drugs compared to those with ADHD. Significant differences were also found for those who used in the past but not today, with higher prevalence among the ADHD group. When examining the onset age at which participants began using or experimenting with soft drugs, we found that adolescents with ADHD were significantly more likely to try soft drugs during adolescence compared to those without the disorder. However, no significant differences were observed between the groups during their 20s. Regression analysis supports the unique contribution of ADHD symptoms to soft drug use, beyond comorbidities and demographic variables. No significant group differences were found in general risk and benefit perceptions when assessed by gut feeling. However, the psychometric paradigm reveals a more nuanced picture. When examining the correlations between ADHD symptoms and the characteristics attributed to the activity in question, ADHD symptoms were found to be associated with strong perceptions of benefit. Additionally, anger management was correlated with symptoms of hyperactivity and impulsivity, but not with inattention symptoms. No correlation were observed with risk perception. When examining the correlation between the symptoms of the disorder and the characteristics attributed to the activity in a categorical manner, comparing individuals diagnosed with ADHD to those without, it was found that ADHD symptoms are associated with stronger perceptions of benefit, particularly among those with predominant hyperactivity and impulsivity symptoms. Perception of risk, however, were correlated only among individuals with predominance of inattention symptoms. If we do a zoom in, for adults with ADHD, the use of soft drugs appears to address unique needs associated with the disorder, which must be considered when addressing this phenomenon in this population. These findings having practical implication for treatments and awareness efforts related to soft drug use, while interventions for individuals without ADHD might primarily focus on social pressure. Approaches for those with ADHD should prioritize addressing the disorder's specific needs, such as emotional regulation, anger management, and improving attention. Additionally, exploring the potential effects of medication on the relationship between ADHD and soft drugs use could provide valuable insights. To conclude, these findings of the study align with existing research confirming a link between ADHD and increased use of soft drugs. The study's innovation lies in highlighting the critical role that perceived benefit plays in the relationship between ADHD and soft drug use. This underscores the importance of addressing perceived benefits in designing treatment and intervention programs for adults with ADHD. Another conclusion is that the behavioral economic approach can produce significant research conclusions regarding the use of substance use among people with ADHD.
Article that has two main aims. The first one is the presentation of current ways of understanding selective mutism, and the second aim, my aim will be to present the description of patient's therapy based on CBT model, and I will try to present it in a, I would say, understandable way. I would like to emphasize that there is no apparently no coherent model of development of this disorder. We still can find different kinds of models and different, I would say, trials of tests and descriptions of patients, but we still don't have the one coherent, the most, I would say, important for therapists. So it's even harder to describe the patients. According to the latest DSM-5 classification, selective mutism was moved to a subsection of anxiety disorders. So the main symptom is, of course, connected with anxiety. The cognitive behavioral therapy is perceived as treatment by choice, and it's mainly related to overcoming the child's fear against speaking. So the psychotherapist's aim is to adjust I would say, the cognitive behavioral model to a particular patient. The main aim is, of course, to overcome child's fear against speaking. And the worst situation, I think that, in my opinion, is that the access to qualified therapists is very limited nowadays. And that's why parents appear in office or hospital or any kind of place that is aimed at helping too late. So it really, this whole process is really, it really takes a lot of time to overcome this anxiety. Of course, selective mutism appears quite rarely in about 1% of patients, usually during childhood among girls and bilingual people. Even though it's not diagnosed very often, it's, in my opinion, worth knowing how to help children with this kind of diagnosis. And it was, if we talk about classification, like this evolutionary classification, it was classified for the first time by Adolf Kasmal in 1877, and it was called aphasia voluntaria. And in DSM-5, the classification of the name went from elective mutism to selective mutism. And to diagnose selective mutism, we need to have the 3 criteria must be fulfilled. The first one is the correct or close to correct level of understanding of speech. So the child needs to understand somebody else's speech. The second one is his or her speech competence must be sufficient for social communication. And the third one, the last one, a child can speak in certain situation normally, usually with his close relatives, but for example, which happens again the most often, he or she doesn't speak at school at all. Or to a limited extent. This disorder must last for at least a month, so it can't. It must fulfill these criteria. And if you talk about clinical picture of selective mutism, like the communication difficulties, they are very diversified, like from the complete lack of communication to cease of using spoken language in certain situations and with few people. So clinical picture can be really, really diversified. And the symptoms usually appear the most frequently, as I said before, in school. And the age group that the review of literature shows that the age group is usually from 2.7 months to 4 years old. And the most visible symptoms appear when the child starts school. And the most, I would say, harmful effect show like the effect of not having help is also very important to prepare this diagnosis, to diagnose the child as soon as it is possible. For the long time, parents usually don't see the problem, and during school education, the problem seems to be even more and more serious. And if we talk about now about etiology, like the causes of selective mutism are not well known. So this etiology is multifactorial. There are, of course, the data that we have, which is limited, but I analyzed different articles concerning mutism, and it turns out that traits such as taciturnity and family background, that parents also have similar problems, and temperament, especially the trait called behavior inhibition, they are very, very important in developing this disorder. And the mechanism, the most important, is of course avoidance. The child starts avoiding speaking, and of course the appearance of trauma, any kind of trauma. Like in my patient's case, it was trauma connected with going with grandma to the grave, and the grandma told her that she shouldn't tell anybody that she was there with her. And from that moment, of course, with different, with additional factors, the child, the girl, stopped speaking. And if we talk about Emotions, of course, there are different problems, emotional regulation, and they are focused on inhibition and limited ability to regulate these emotions. Of course, it is clear that any kind of neurological disorders are, of course, very important factors to develop this kind of disorder. If we talk about epidemiology, it may be also recognized mutism among adults, but it happens more rarely. And it's more often categorized as social anxiety disorder. So it's I think it's advisable to remember about the fact that also adults can be diagnosed with selective mutism. Going to the part connected with treatment, different authors say that mutism is described as a disorder difficult to treat. Mainly we've got case studies, and so is my article focusing on case study. Among the most commonly introduced behavioral strategies were positive reinforcement, modeling, exposition, and curbing fearful stimuli. And one of the most popular treatment connected with lowering anxiety, that is SCAT, so social communication anxiety treatment, is an example of efficient therapeutic program. And of course, it's very advisable to, and sometimes I would say even it's a must to involve parents in this treatment. And if we talk about medicines like pharmacotherapy, children who were treated with SSRIs, they were observed as great symptoms decrease. So I think it's very important to, if there is, of course, a need to consult their child with psychiatrist. And my therapy plan description was based on Dr. Elisa Shippon-Blum's guidelines, the head director of the SMART Center in the USA. So it was very helpful for me to read all these guidelines. And of course, I was focusing on this program that I aforementioned, SCAT. And the first stage was focused on non-verbal actions such as nodding, pointing, gesturing. And the second stage was named transitional period. That use sounds that are helpful to communicate. And the final stage was about verbal response, like whisper, silent conversation, and reading aloud. And my patient, who was 11 years old, she at the beginning of therapy, she was very she was full of anxiety, and she didn't want to cooperate. But I was aware of the fact that that she needs to get some. She needs to go through therapy, and her symptoms were observed since the beginning of her education. So she talked to her parents, to her close relatives, but she didn't talk to her teachers and many school mates. And it turned out that she also has different problems with education. So she went through diagnosis, intellectual. So it turned out that she needs to have some steps, I would say, introduced to help her. The negative automatic her thought was, I won't speak, and many people thought that she is, I would say, a person who tries to manipulate different people, but it, of course, wasn't true. And as the therapy was going further, she was more and more involved, and at in the end of the therapy, she started a conversation with teachers, and I was really pleased that her life has become more and more, I would say, tolerable, and her level of anxiety has become definitely lower. And to be honest, the therapeutic process was elongated before the effects were visible, mainly because of her anxiety. And it was very, I would say, demanding for me as a therapist to have sessions focused on different activities without any words. So it was very, I would say, demanding, as I said. There were, of course, different expositions, like going to the restaurant or asking a shop assistant to buy something. But the more involved she was, the easier it was for her. And of course, it's very important that parents were very cooperative, and they helped me to overcome her fear. So she started speaking to different foreign people, and she talked about. She spoke willingly to parents about her emotions and the difficulties, and it has never appeared in her past. And to finish my presentation, I would like to stress that a very limited number of research doesn't help to, as I presented at the beginning, to create the cohesive model of this disorder, but I hope it will change. And it's very hard to understand patients who suffer from selective mutism because they often lack current knowledge and experience. And most of therapeutic approaches stress the behavioral components in the cognitive behavioral conceptualization. And it's very important to have this psycho-education part with parents to make them be aware of different problems. And of course, we are during the therapy, our aim is to rebuild child's trust. So that's all. Thank you for taking part in this conference. And do you have any questions?
Professor Borak. As you mentioned, I am right now in Switzerland, but all this research comes from Germany, where I have been working for many years. And my presentation deals with ShuntScope application in treatment of pediatric hydrocephalus. We'll discuss the indications, surgical technique, and results. So just briefly, the accuracy of ventricular catheter placement is indeed very important and critical issue because it significantly influences and correlates with the functionality and the shunt survival rate. And looking through the literature, we know that even though the application of ventriculoperitoneal shunt is generally a straightforward and easy procedure, we know that the misplacement of ventricular catheter is indeed very high, and this is estimated for up to 45%. So therefore, for this reason, the efforts have been made how to improve this accuracy of ventricular catheter placement. And therefore, for this reason, the so-called ShuntScope has been created and implemented in the treatment of hydrocephalus. And for whom of you who are not familiar with the ShuntScope is a type of endoscope. This is the product of Karl Stotz in Germany. And for its special features such as outer diameter of only 1 millimeter, image resolution of 10,000 pixels, indeed, this is very practical and very helpful intraoperative real-time tool for shunting procedures. So about our research in the period of 10 years from 2011 to 2022, we performed 65 ShuntScope-assisted procedures in 51 children. Mean age was 5 years. Looking through the pathology, the most common pathology treated with application of ShuntScope was the tumor or cyst-related hydrocephalus. It was in 26 of cases. After that was hydrocephalus communicans, 24 of cases. The third important indication was isolated foreventricle after shunting, 8 of cases, and less was pseudotumor cerebri, intranistic aqueductal stenosis, Dandy Walker, craniosynostosis, and post-traumatic hydrocephalus in children. In regard to the procedure, as you can see, the most common surgical procedure we consider to use intraoperative the ShuntScope guidelines was the borehole reservoir insertion. It was especially important because, as you know, the position is indeed very important, particularly when we, for example, when we treat patients with oncological, for example, patients with chemotherapy or antibiotic therapy. So in these cases, the ventral catheter had to be optimal positioned, and borehole was placed in 19 of cases. The other indication was shunt revision surgery, also very important, 14 of procedures. The third important was transaqueductal stent placement for aqueductal stenosis, and less was transcystic, transforaminal, transeptal ventricular catheter placement, as you can see in this diagram. So we divided the intraoperative achieve ShuntScope image into the 3 main categories, as you can see: the excellent image, medium image, and poor image. The excellent image, as you can see, this is really a beautiful and great image, great quality. You see all intraventricular landmarks with foramen of Monroy, plexus, choroid plexus, all septal veins, and so on. The middle image, as you can see, is also enough, sufficient. You are able to see that we are in the ventricle system, and this is absolutely sufficient for intraventricular orientation. However, this is not as optimal quality as you can see in the excellent one. And in the third, as you can see in poor image, we know we are in the ventricle system. However, we are not able to use it for intraoperative orientation. And from the radiological point of view, after operation, the patient received CT scan or MRI scan. And for the orientation, for the assessment, we use the scale for Professor Caroline Heihart's. This scale was presented in 2010, and it was the grade 1, 2, and 3. And you can see that the grade 1 indicates an optimal position of the catheter, ventricular catheter placement, no touch to ventricle wall, no touch of choroid plexus. Grade 2, it was suboptimal position, so still the ventricular catheter is inside into ventricle. However, there's a small piece touching the choroid plexus or or ventricular wall. And the third grade is the grade with false positioning extraventricularly. In all those cases, the ventricle catheter had to be revised. So this is our results. As you can see from the one side, ShuntScope assisted images quality. We achieved an excellent image in 41.5%, medium image in 43%, and in 15.5% we have a poor image. On the other hand, from the radiological point of view, as you can see, the grade 1, so that means the optimal position of the ventricular catheter we had in 77 of cases, grade 2 in 21.5%, and in one case we had an extra ventricular position. Additionally, we wanted to know whether the treatment and the image quality and treated pathology correlates with each other, because in some cases, as you know, for example, post-hemorrhagic or tumor-related, for example, meningiomatosis carcinomatosa, we know that the liquid contain a high level of protein, and it can, for example, then correlates negatively with the image quality. And we haven't found any correlation, and the p-value was 0.19. So from our results, again, the optimal position was seen in 77%. The ShuntScope sufficient image quality was achieved in 84.5%. So that means we haven't had any statistic correlation between ShuntScope related image quality and the accuracy of the ventricular catheter placement. One thing is also to say that in one case, the intended transaqueductal stent placement for aqueductal stenosis had to be abandoned and to switch to the ventricular catheter placement because the periaqueductal area was very difficult and distorted, and the entrance of the aqueduct was not seen. Additionally, we haven't had any intraoperative ShuntScope related complications. So mean follow-up was 39.7 months, and the proximal shunt failure rate was estimated in our series for 4.61%, because in 2 cases treated with ShuntScope assistance, the ventricular catheter had to be revised in the further course because of tumor or cyst grow, and consequently the tip of the catheter was occluded. So therefore the catheter had to be changed. And there's the illustrative case. As you can see, the 7-month-old boy with premature hydrocephalus. Initially, he has been treated with a classic ventricular peritoneal shunt, and a few months after this treatment, he developed a so-called isolated foreventricle with inflow and outflow occlusion and consequently aqueductal stenosis. And in this case, we indicated that the further treatment with ShuntScope-assisted transaqueductal stenting. And there's a corresponding video before I start. Only I want to say you that the ventricular catheter preoperatively had to be prepared. So that means the tip of the ventricular catheter had to be cut. And after that, the intraluminal endoscope is put into the transluminally into the catheter, and then both of them go to the borehole. So we perform the borehole right frontal, and right now in the lateral ventricle, you see a white foramen of Monro as a sign of chronic hydrocephalus. Right now, you see the floor of the third ventricle with the classic landmarks. You see the mammillary body, and then from the up 11 o'clock, right now will be infundibular recess as well. And after that, we switch to the dorsal part of the third ventricle. And right now, see that the entrance of the aqueduct absolutely occluded, narrowed. Also the posterior commissura from the 5 o'clock, as you can see. And right now, the ShuntScope together with the catheter is protrude further through the aqueductal area. And right now, we are in the foreventricle, so also you can explore the foreventricle and to be sure that our catheter is correctly placed, and then to produce it a little bit. And after that, when we are sure that is correct, so we withdraw the ShuntScope and the procedure is closed. And this is a postoperative image 4 days after surgery and 14 months after surgery. You see the beautiful image and correct position of the transaqueductal stent. You also see that the foreventricle is is significantly decreased, especially 14 months after operation. Also, you see the prepontine system with the basilar arteries, beautiful to see, is enfolded. Also, the foreventricle and also the cerebellum is really enfolded. So this is an optimal postoperative image. And also the patient was doing clinically very well. So in conclusion, we can say that the ShuntScope, from our perspective, represents a reliable, very helpful intraoperative image guidelines, particularly in the very difficult situation, for example, tumor-related, cyst-related, when you have a ventricular asymmetry. So this is indeed very important to do it with ShuntScope, so you can find a proper corridor, and we encourage others to use it, and its application should be considered more frequently. Thank you very much for listening.
This is an indication for a brief dynamic psychotherapy. Next slide, please. The concept of algorithm is currently dominant in both pure and social science, psychology, sociology, and in institutional culture, public and private companies. The algorithm also is a sequence of actions that can be used to solve problems and that are not necessarily formalized in the mathematical language. Next, please. So the algorithm can be conceived as a concept similar to the nature of the psyche, precisely because it links to one of the possible psychic tools which must coexist with in a non-logical mental functions. Next, please. So we hypothesize an analogy between Jung's concept of the algorithm and the concept of the complex. The complex is a Jungian concept in the theory often called psychic theory of complex, paternal, maternal, fraternal, and so on. Next, please. The complex is defined by Jung a set of images united by a strong central affective tonality. For Jung, the complex is the royal road to the unconscious, is not constituted by dreams or free association, but precisely by the complex. Next, please. Last but not least, the element of affinity between complex and the algorithm is the strong central affective tone of the first, which coincides with the communicative interactive theme of the algorithm. Next, please. This concept can be amplified by the core conflictual relationship theme by Luborsky, whose essential components are the wishes and expectation of the subject. The CCRT seems in the symptoms the expression of an intrapsychic conflict originating from the representations structured during childhood and conserved for the entire life. Next, please. In a Jungian psychotherapy perspective, it is important also consider the communicative orientation. This is a form of brief psychodynamic psychotherapy combined with a psychological, analytical, communicative orientation. Next, please. It seems important to define that the brief psychodynamic psychotherapy represent one of the psychotherapy empirically supported treatment, so the evidence-based treatment. Next, please. Moreover, a consensus conference identified also the brief psychodynamic psychotherapy together with cognitive and behavioral therapy and interpersonal therapy as the only exclusive psychotherapies based on the highest level of efficacy for the common mental disorder or common emotional disorder, as we nominate now. Next, please. The brief psychodynamic psychotherapy, in our opinion, define the duration of the treatment in 16 sessions agreed at the beginning with the patient and identified the CCRT, as Dobowski say, as the method of this clinical approach. Next, please. Next, please. Thank you. With these premises, we will illustrate a clinical case with particular attention to the fraternal complex. In recent years, psychoanalysis has witnessed a significant revival of interest in the problem of the fraternal dynamics. Next, please. We speak of a fraternal complex where the unconscious intrapsychic moral conflict is present. The patient, a 31-year-old woman, demonstrated both high-level defenses, such as anxiety, and low-level defenses against awareness of this conflict, such as a polyvagal and psychosomatic defensive reactions, like headache, stomachache, enlarged glands, skin rash, fainting reaction, a classic activation of the polyvagal system. Next, please. The stimulus event at the beginning of this analysis is a stressor, an external to the patient. And here we use the term in the meaning adopted for the Lubowski CCRT, which does not take into account the possible presence at the basis of the patient's symptom of an unconscious intrapsychic conflict determined by his ambivalence toward her sister, loved and hated at the same time. Next, please. She also attributed psychic strength and aggression to her sister. It is obviously a matter of a force, which is the expression of a hypomanic attitude of denial of the event. In the context of the complex that has been studied with the stimulus event, the patient nourished strong self-image. Next, please. The image of the mother is distressed by a state of alarm, affected by a sense of helplessness and despair. Why did it happen to her, your sister? The patient linked her symptoms anguish to an experience that was unleashed in the virulence both by the awareness of her sister's illness and by the period in which she accompanied her to the hospital, seen as a cold, anonymous structure. The hospital therefore acted as the symbolic equivalent of a mother who responds to the desire for warmth and affection in a cold and negligent way. Next, please. The defense used was the mechanism of avoiding the sister illness topic, generator of pain, displeasure, and malaise in her, in our patient. When the therapist connect this pain, which the patient can experience only on a bodily level, with her physical symptoms, the patient could finally allow herself to experience her fears, for example, the mourning for the sister's disease. Next, please. Following this experience of pain, she questioned her sense of autonomy and independence related to her professional efficacy, which, however, were accompanied by a feeling of loneliness caused by the special distance from her boyfriend. Before her sister's illness, she felt very strong, no less so. She projected into her sister a latent aggression towards the possibility that the latter would undertake a possible profession, the impulse not to work and study anymore, which for the first time she began to feel recently. Next, please. However, she had a reaction to her sister's illness because she dreamed of her dog in a garden full of flowers and light, smiling at her. That is an unconscious instinct for life and the delight of truth. It is the only positive element in a sea of pain and suffering related to anxiety. Next, please. In conclusion, the analysis conducted with this brief psychodynamic psychotherapy with a Jungian communicative orientation on the complex, while revealing a development that starts from the recognition of this in the patients. Next, please. The fraternal complex, as rediscovered, is healthy functionalist in the process of acquisition by the patient of the ability to experience and to possess the reading key of her positive and negative feelings, no longer polarized as opposites, but dissolved by a synthesis that has driven the patient at an higher dimensional level of her personality. Next, please. Thanks for your attention. And thanks for the invitation to present our work. Thank you very much.
Function is to bring emotions to consciousness and awaken elevated feelings. I'm going to talk about these themes, the Natya Shastra tradition and today. It's a traditional text, and art and emotional states, description and functions. Here's some information about this text. The Natya Shastra is one of the oldest and most important treatises on classical Indian dance theater, whose authorship is attributed to the mythical Bharata Muni. It's not known exactly when it was written. The date of its composition is extremely controversial and may vary from the 5th century before Christ to the 6th century after Christ. The word Natya has been often translated as drama, but in Sanskrit dictionary, the meaning is much more broader. Natya is translated as dance, dramatic representation, scenic art, actors attire. In this, in tradition Hindu culture, art has the function of educating and awakening good feelings, in addition to leading the viewer to identify with some aspects of the representation, especially classical dance, with its gestures, which are the mudras and symbols, and produces elevation to the soul. In Aristotle's Poetics, he states that the spectacle is the most exciting, but also the least artistic and least proper to poetry. Because even without representation and without actors, tragedy can manifest its effects. Abhinava Gupta, in the text restored by Kulkarni, states, on the contrary, that when poetry is not performed, it's not possible to have complete aesthetic pleasure or rasa, which is a word, Sanskrit word to taste. Nevertheless, there can be some aesthetic pleasure in reading alone if the poetry, through its vivid and elegant descriptions, acts as a drama or on the stage of the spectator's mind. The Indian philosopher considers natya, the Sanskrit theater, described in the Natya Shastra, as drishya kavya. It's visible poetry, a type of poetic composition that's addressed to the eyes and ears, and not just to the ears like written poetry. The concept of drishya kavya combines the visible and the poetic, so that the flavor of the mixture is different from the flavor of the two elements separately. It combines then the two senses. According to the Natya Shastra, the actions of the gods are naturally just, but the actions of men require conscious effort. So all the details of these actions must be rigorously prescribed. In the Natya Shastra, the movements of the various parts of the body and body postures are described in detail as in a dance choreography. It establishes all the postures and gests that can be done so that the representation is understood. Some poses portrayed in statues and decorations of various temples in India, such as Konarak in Odisha and Sitambaram in Tamil Nadu, were found. I have here some images. This is of the temple of Konarak and this of Nataraja temple. These traditions were recreated in Orisi in the wake of the Indian dance revival movement, based on various references, thanks to the collaboration of numerous teachers, students, and scholars, dancers, organizations, and institutes. But today, these traditions lost their ritualistic function and became an artistic fact. In a classical formatted show of this style, a single actress dancer dressed in traditional costume plays all the characters in the story. A central idea of these texts is that art is a reiteration of cosmogony. This reiteration or mimesis is the very measure or criterion of validity of art. In the beginning of the Natya Shastra, Bharata, the author, says that this is the fifth Veda, and this is a request from the gods that are listening to him and asking him to compose this fifth Veda. This mythical configuration of the Natya Shastra differs significantly from what we can find in the four Vedas. in many archaeological discoveries, we find references to Shiva, who is the dancer. The dance of Shiva creates and destroys and recreates the world. We can point to the presence in medieval Hinduism of elements of the culture of the ancient cities of the Indus Valley, which are Mohenjo-Daro and Harappa. Although this, Although this predates the Vedas, it's plausible that such a civilization cultivated some practice of bodily techniques similar to those that appear in relatively late historical documents of Hinduism under the broad designation of yoga. It's plausible, and we find in this place this statue of the bronze dancer that was found in Mohenjo-Daro in 1926. It's wrong here, 1926. And probably it was produced around 2,500 years before Christ. When the gods ask Bharata to compose this 50 Veda, he says this to them: remain pure and attentive and hear about the origin of the Natya Veda conceived by Brahma, or Brahmins, in ancient days, when the golden age ended along with the reign of Svayambhuva, and the silver age began in conjunction with the career of Manu Vaivashvata. People became attached to sensual pleasures, fell under the influence of desire and greed, became affected by jealousy and anger, and thus found their happiness mixed with grief. This puts in a clear way what is the function of the arts, theater and dance in India, because to pay attention to our senses, to our feelings, is important to learn about them and not to be taken by them. So they ask Bharata to talk about these objects of enjoyment, but they should be a way to learn about our emotions and our feelings. So these first chapters begin with a series of questions addressed by the sage to Bharata, who proceeds to answer them. First, saying them what is the purpose of these arts. And so when talking about this to the gods that are listening to him, he calls the attention to the reader, because the reader must have the same position as the ones that are listening to him. In the 6th and 7th chapters of the Natya Shastra, this Bharata is going to talk about the concepts of aesthetic experience and emotional state and the performative expression. These words, as you see here, aesthetic experience as rasa, emotional state as bhava, and performative expression as abhinaya. And these are the conceptual core of Bharata's poetics. Here you have a quotation of this of the text, where the gods ask Saj Bharata to answer these 5 questions. Explain to us how the aesthetic experience enumerated by the connoisseurs of performing art achieve their characteristics, and why the emotional states are so called and what they arouse in us. Furthermore, what are the actual meanings of compendium, memorial verse, and derivation? These are the questions that the gods address to Bharata. So he explains what compendium is. Compendium is the synthetic exposition. When the themes taken in detail are synthesized and collected in a small number of aphorisms and their commentaries, these constitute, according to scholars, a compendium. Then the next concept, memorial verse, which clarifies what has already been uttered, the analysis of the roots, that is nirukta. The delineation of this entire vast edifice, its floor plan, is given for the first time in the following lines, where then Bharata explains the function of all these elements. Aesthetic experience, rasa, emotional states, bhava, performative expression, abhinaya, practices, dharmi, styles, vritti, local customs, success, notes, classes of musical instruments, incidental music, and the stage, all of this constitute the compendium. So the compendium is every material and every means that is used to the composition of a dramatic piece or a dance piece. So what then is rasa and bhava? That is the most important, these are the most important concepts that I want to talk about here. Bharata affirms no meaning can arise in the absence of aesthetic experience. So rasa is the most important effect that the dramatic piece or dance piece can produce in the audience. So rasa is so called because it's capable of being pleasantly savored. So he compares this effect on the audience as experimenting something, trying something, tasting something. So, but it's not, of course, the same as a flavor of a fruit or a food. In art, finally, flavors are essentially of the modes of sensitive experience that, as we will see, are tasted in a depotentiated way, given their nature of mimes, both in the objective and subjective poles. He mentions an educated person and the experience of this educated person in his mind is the fundamental emotional states through the expressive planes. This is called the aesthetic experience of performing art. This educated person is a qualified appreciator, perhaps another artist who has developed his sensitivity and art critic. In short, he is a connoisseur. It's quite illustrative of the idea that underlies Bharata's aphorism, that is the establishment of a fundamental grammar characterized by the succession of emotional states, which is related to the expressive planes as a fundamental instance of generative path. To clarify what such generativity means, it's necessary to explain what is understood by emotional states, bhava, and experience, expressive planes, abhinaya. These experiences, I will finish here with some quotations of the Natya Shastra that initiate an explanation of these states.
Okay, doctor.
Aesthetic experience rasa springs from emotional states when they are imbued with the quality of universality. So it must be an experience that everyone is capable to feel. Emotional states, bhava, which proceed from that which is congeneric with the heart, are the source of aesthetic experience, rasa, and pervade the body just as fire spreads over dry wood, which means also, well, the same meaning that is everyone is capable to feel, and the author is going to give images that certainly everyone is capable to feel and learn. Thank you very much. I am Sonia Campaner from Pontifical University, Pontifical Catholic University of São Paulo. Thank you very much.
Thank you so much, Dr. Sonia, for the excellent presentation. So any questions from the audience side?
Central nervous system pathology is the second most common degenerative disease, and it reaches 1 to 2 individuals in 1,000 in the general population, and it can start earlier. It's not a cognitive, an aging disease specific to the aging population. So with 45 years old, you can start having the symptoms of Parkinson's. Although Parkinson is well recognized by the motor symptoms as bradykinesia, muscular stiffness, resting tremor, and postural stability, it can also present a lot of non-motor symptoms like anosmia, anxiety, dementia, depression, constipation, dysexecutive function, alteration in sleep, REM stage, and attention and memory deficits. So concerning to the neuropsychological changes in Parkinson's disease, we have most of them in memory, language, dysexecutive syndromes, and vasoconstrictive alterations, but most of them can experience as well dementia. So 26% of the patients with Parkinson's disease can start having dementia in the beginning of the pathology, and 78% can experience dementia after 8 years from the diagnosis. Concerning as well the neuropsychology changes, we have a dual syndrome model proposed by Keyhaja, in which we have two kinds of the neurodegenerations, that can lead to different deficits in the neuropsychology. So we have the frontal striatal degeneration. It's mainly based on dopaminergic loss and in the basal circuits, and leads to attention and executive function deficits. And we have the cortical posterior, which is mainly the cholinergic degeneration, the posterior cortical basal, which can lead to recognition and memory and visual spatial skills deficits. In relation to the neuropsychiatric changes in Parkinson's disease, the most common neuropsychiatric symptoms are anxiety, depression, apathy, and psychosis. And it occurs with the patient at some point of the pathology. So most of them will experience at least once one of these neuropsychiatric symptoms. And the two most common is the anxiety and depression. And we can see that in 30 to 40% of the patients. So we're going to talk about neurofeedback, we have to talk about neurophysiology. And when we understand, the way we understand neurophysiology is because the neurophysiology is it's formed by the brain waves that's captured by the EEG, and it's the product of the cortical neuroactivity. These brain waves are formed by the potential differences of the neurons in the cortical area, and they are decomposed in form the sinusoidal waves that we can divide in the frequency bands. So we have delta, which is 1 to 4 hertz. We have theta, which is 4 to 8 hertz. We have alpha, which is 8 to 13 hertz, beta 13 to 30, and gamma 30 to 60 hertz. I'm going to talk the influence of each one of these waves in the Parkinson's disease. So concerning to beta oscillations, we have that it's very important to coordinate in movements. It's predominant during the stability and the tonic contractions, and they decrease immediately before and during the execution of a movement. In relation to gamma frequencies, the gamma frequencies, it's very important to the neurocomputational, and it's a consequence of the inhibitory postsynaptic potential. So usually is associated with motor processing. The excessive of gamma synchronization can lead to a chaotic synesthetic activity. And when we have the coupling of beta and gamma waves, we have that's very related to motor programming and text mediation. So when we have the increase of this coupling between beta and gamma waves, usually we have the symptoms of bradykinesia and stiffness in the Parkinson's disease. Concerning to alpha desynchronization, it releases in the motor region and usually associate with the responsiveness. So the desynchronization of the alpha in the basal ganglia promotes the idle state. And it's very important to an effective motor response programming, which is very related to the Parkinson's disease. The excessive oscillation of theta waves may be related to the resting tremor. In the frontal region, it may be related to the freezing of gait. What is neurofeedback? Neurofeedback is the regulation of the brain waves activity using technological interface, which is most commonly the computer, and where the individual can regulate their brain activity. So in summary, it's the operant conditioning of the brain waves activity by the EEG. So we use the EEG to capture the brain waves, and the computer will decompose, and we have like, I would say, we have a target that can be an increase of alpha activity, and as the subject increase the alpha activity, the computer will feedback them with some movements, some images, some audio information, maybe a video, and this response that the body has will condition your experience, and then you're gonna have this change in the brain waves. Neurofeedback presents several protocols. Some examples of the clinical application of this neurofeedback is in epilepsy, in ADHD, and anxiety and depression. Concerning to Parkinson's disease, the majority of the protocols are applied to improve the motor symptoms, and most of them are concerning to train beta and alpha rhythm. And this is a very similar pattern of the increase of sensory motor rhythm in the ADHD patients at the central cortex. Usually the circuits involved in the action of SMR are the thalamocortical networks, and these reduce the interference of the sensory motor information. So in order to that, we try to use the same protocol of the ADHD patients, which is the increase of SMR, to check how it's going to be for Parkinson's disease patients. In 2002, Cook et al. Used this protocol comparing in a single case. So one person did a training with a SMR of SMR, but the training was in fMRI, not in the EEG neurofeedback, and comparing the on and off medication of levodopa, because SMRIs are also connected to plan, initiation, and imagination of the movement. The results are mixed concerning the motor behavior, but it was observed a change in the beta waves and alpha theta distribution. So our protocol was to observe not only a change in the motor control, but we also want to check if there was change in the emotion and cognitive aspects of the Parkinson's disease, as we could saw at the beginning of the lecture that there is a lot of unknown motor symptoms as well in the Parkinson's disease. So it's important if we can check and see if there is something that we can do to ameliorate these symptoms. We use the Parkinson's disease cognitive rating scale to check the cognitive aspects. We use the Beck anxiety and depression inventory and the Unified Parkinson's disease rating scale part 3 for the movement part. It was only 8 patients with the mean age of 62.25 years old. They were distributed in 3 groups. So we have an experimental group that did 10 sessions of neurofeedback. We have a placebo group that did 10 sessions of sham neurofeedback. And we have a control group that stayed in a waiting list for the period of the training. We did, before the 10 sessions of the training, all those scales that is described. And afterwards, like after 10 sessions of the training, we did the same scales again to compare it. The control group that did not make neurofeedback, after the 5 weeks training, we did the measurement. We did the first measurement, and then we did the second measurement, and then we put them in a group. or an experimental or a placebo. So our protocol of neurofeedback is an EEG protocol. We did the SMR training at the CZ area at the central cortex. It was the response that the person would have. It was from images. It's an images of nature when they achieve the increment of the SMRI. They have the feedback of the computer. Our results were conducted with t-tests or one tail pair samples, where the subjects would compare the BAI, BDI, and PDCRS, and the UPDRS. So we have the emotional, we have emotional compared to anxiety, the depression scale, the cognitive scale, and we also have a motor scale. What we have as a result was that we have a change. So they diminish the anxiety symptoms, they diminish the depression symptoms, and they also improve the cognitive symptoms. But concerning the cognitive symptoms, we have two results. We have the results of the neurofeedback group experiment and also the sham neurofeedback group, also presented an increment in the cognitive stage. So in order to understand if it was really the neurofeedback that makes the changes, we compare the results according to the dual syndrome. So these tests, the PDCRS, they have two results. They have the frontal subcortical result and they have the cortical posterior results. And when we check that, we could see that the neurofeedback group, the experimental group, have a statistical difference in the results of the subcortical when they have an increment of the subcortical results. That is, they have improvement in this cognitive area, but they didn't have this improvement, the same improvement in the cortical posterior. So what we have was that there is no motor difference between subjects. So the patients with Parkinson's did not have an increment in their motor or diminished in the motor symptoms using the neurofeedback, this kind of neurofeedback. However, they have an increment or an diminished of their symptoms in anxiety and depression. As well, they have an improvement in their cognition. Those patients were not with a depression characterized a condition of depression or anxiety, but they have symptoms, and these symptoms ameliorate, so they were better in this condition. We also have that in concerning these cognitive scales, we have that the significant subcortical increase and the significant decrease on cortical posterior results can imply that this SMRI neurofeedback increased the attention and working memory, which is a very common result of the neurofeedback. We can associate that to the dopaminergic pathway in the superior cortical area. That is, so we have a change in this, probably a change in this area, which is influence the activity of the basic circuits. Also, the results in emotion and cognition observed by the experimental group demonstrate that the regulation of SMRI can modify the emotional and cognitive capacity in patients with Parkinson's disease, which is very important because we are dealing with a degenerative disease, which is different from a training in a brain that, although it has alterations, but it's not diminishing their abilities with age or with time. So it indicates that the neurofeedback is an attractive tool for any disorder that involve imbalancing neurocircuits, and also indicate that it's clinical difference. So it's very important for a clinic when we have this experience with clinical patients that we can have tools to increment or ameliorate their symptoms. It's well known that the neurofeedback can improve the cognitive of old age. So it's a tool that we can improve cognition, but we have not tested yet in the case of degenerative disease. So testing that we can also use for clinical application. It can also be, we can also infer that the changes in the neurofeedback also change the beta pattern, observed by the difference in the percentage between the first session and the last session of neurofeedback. So the oscillatory desynchronization in beta activity over the central cortex during a motor execution reflects the decrease in amplitude and force of beta activity, which is important because usually the Parkinson's disease patients has an increase in beta activity. So if we can decrease that, it's we are also changing the plasticity of this brain. So according to Gomes, the SMRI provides a related event of desynchronization in beta activity and a related event rebound of synchronization in alpha activity, which can lead to a long-term potentiation, consequently plasticity. So we can also infer that with this training, we could provide some plasticity in this brain activity. Also, the change observed in cognition from the neurofeedback training can be related to the improvement in attention and working memory. The attentional improvement are or may be also related to the executive functions that's impaired in Parkinson's disease. So when we have the improvement in attention and working memory, consequently, we can also improve the executive function. So the cognitive improvement can interfere with the emotional improvement as well, because both of those variables benefits from the training. So to conclude, the results that we obtained in the present study demonstrate that the SMRI protocol of neurofeedback remain in line with the other common training results, even when applying a degenerative condition, which demonstrate the ability to generate changes in cortical basal circuits, inducing neuroplasticity. Although we have the limitations of the sample size and the EEG collection, which was not very broad, we just had the collection of the CZ area, not with many channels. So if we can, it would be nice for future studies that we can also test some other scales, neuropsychological scales of executive functions, or as well scales that can evaluate aspects of apathy, memory, attention, executive functions, and expand and training for other frequencies such as beta, or alpha frequency, as well a spectral collection of the EEG, so we can check the whole cortical area, how it was changing. Thank you.
Thank you so much, Dr. Valeska, for the presentation. So any question from the audience side?
At the FOP Clinic, in Portuguese, Fonoaudiologia Pinheiros, mainly with neurodivergent children in the areas of language and orofacial motricity. I am part of the dissemination team of the journal Communication Disorders, Audiology and Shallow Encodas, which is a technical scientific publication of the Brazilian Society of Speech and Hearing Therapy. I am a preceptor on the speech therapy course at USP, and I'm part of mental health group in primary health care. I was a fellow at the Child and Adolescents Institute at the Hospital das Clínicas of the Medical School at the University of São Paulo. It's a pleasure to present the research entitled Risk Factors that Influence Language Development. This research was carried out in Brazil at the Laboratory for Speech and Hearing Research in Primary Health Care, in Portuguese LIF APS, at the University of São Paulo. Language is the main method that humans use for relaying information, consisting of words conveyed by speech, writing, or gestures. The combination of biological, cognitive, social, and environmental factors is highly important for the child's learning process. The risk factors associated with biological and environmental factors, such as low parental education level, relationship by blood, family history present to speech-related issues, and inadequate stimulation, may result in speech and language delay. Firstly, this research aims at correlating the results found in the PDL with the answers obtained in the PFRAL to identify the most significant risk factors for child development, above all language disorders. Secondly, our objective is to interpret the results found. Thirdly, we aim to provide research that will help formulate public policies for the population in question, while focusing on prevention, promotion, and early intervention. In that sense, this research has a local context. This study was approved by the Ethics and Research Committee, speech therapy protocols that were applied from 2016 to 2020 in primary health care for screening changes in child development were analyzed. For this study, participants aged up to 5 years and 11 months, early childhood, were selected. After exclusion and inclusion criteria established, total 194. All the participants that have PDL were correlated with the questions of the PFRAL, like child's gender, race, time interval between the first speech-language pathology complaint and the child age, family history, maternal education level, paternal education level, maternal age, time parents spend with their children, mother's temperament, father's temperament, child's temperament, socioeconomic status, and other questions. The PDL results were analyzed in two axes according to the child's age group: listen and understanding, and speaking. The result was considered altered when the participants present over 50% negative answers in at least one of the two axes. Alterations in both axes were not needed for the result to present as altered. PFRAL. The following variables were selected and analyzed in contingent tables correlating with the PDL result, social demographic questions, family life, prenatal, perinatal, and postnatal care, and temperaments of the child. Out of the 121 participants analyzed in this study that present sheltered PDL, the prevalence was male in relation to the total. The greatest demand for speech therapy services found was declared as Caucasian. Most of the maternal and paternal education level answers were high school. Pre-pedi and or postnatal complications, only the diagnosis disease obtained statistically relevant values, although it's important to emphasize that the sample size may influence the result found here. This table shows us another question addressed in the protocol was the temperaments of the mother, father, and child. The altered temperaments of the children was noteworthy. When analyzing only the altered PDL and comparing its correlation with the temperaments of the child and the parent, we have observed the statistically relevant numbers for altered parents' temperament and altered child temperaments. The time interval between the point in which the parents' guardians sought the speech therapy service at the first complaint age of the child minus the age at the first complaint. To analyze these variables, a group of participants, 20, was excluded since they did not mention the age at which the speech-language complaints first appeared, time interval 0, as well as children who were born with hearing loss and or any syndrome, and the time interval was 0 and or 1 month of discovery of the condition, 5 and 1 respectively. The remaining data resulted in a scatter plot, which shows that the longer the parents took to look for help, the older the child was. The average time interval in months for children from 0 to 5 years and 11 months is equal to 20.1. It was found that the greatest demand for the services is from the declared Caucasian race. In an American systematic review, the data collected presents a correlation between health literacy and issues such as age, race, years of education, and cognitive functions. Children who live in a favorable socioeconomic situation have development disadvantages and are more vulnerable to language-related complications. Paternal education level plays as an important role in the child's cognitive development, given that the literature establishes a correlation between a higher level of parental education level and the promotion of a positive environment for language development. When discussing the children's altered temperament based on the parents' answers, some studies show that mental health-related risk in the first years of life can affect the language developments and child developments as a whole. That is, the imbalance of the mental and emotional aspects of the child's life can contribute to the emergence of difficulties in the acquisition of future skills. Since the first month of life, the child's brain plasticity is very intense. Environmental factors can aggravate psychosocial risk factors and consequently affect the healthy development of a child. Current research shows that the temperaments undergoes modulation at younger ages. The characteristics of the child's temperaments may have an influence on development, but it's not possible to state that will determine the temperament's change. The pre-pedi and postnatal complications may impact on the acquisition of motor and cognitive skills. Furthermore, when exposed to a psychologically unfavorable environment, they experience high-risk conditions for physical and mental health. Since family characteristics are strongly associated with mental health in child development. This research also suggests that future clinical research and clinical work performed by health professionals, especially in primary health care, should consider risk factors that influence children's language development for speech-language pathology and audiology screening. Furthermore, continued studies are needed for improvements in the Brazilian children's public policies of primary health care. Clinical applications of these studies would entail, hopefully, to health professionals in primary health care. The application of these protocols would be as early speech-language screening. The early identification of language disorders might create the necessary bond for continuity of care to the specific family in a risk group. In order to broaden the scope of the topic observed, we hope that the results will imply in the care of the participants the creation and reorganization of public health policies among the other tools that will be used to meet the population's demands, and the continuity of these studies is a great value to scientific research. Speech-language screening is fundamental as it's the first step for many children with language development disorders. A watchful eye on behalf of the health professional is vital so that the focus is not on the pathology and its symptoms, rather on the individuals as a whole and in their insertion and social, historical, and cultural dimension. So here you can have the references, and if you have any questions, if I can help you with something, please contact me, and this is my email. Thank you.
I'd like to send my gratitude to Dr. Maria for the excellent presentation. So,
I must say, an unpredictable world. So, look, yes. So we can, yes. Now, the developing society and new digital technologies, artificial intellect, and so on, have become one of the main problems for our psychology and not for our community, I must say. To see these unpredictable and problems in recent years, in addition to new opportunities that open up prospects for development of the society and of personal growth, it's a very many, I must say, news threads, and these threads are for emotional well-being, personal growth, and self-changing. And we the one of another besides unpredictable world and stress for self-changing, there are the new threat dangerous of a lot of new information and sometimes unpredictable informational flow. And this uncertainty is spreading to communication, learning, and everything. So we want to understand and to check the individual characteristics that contribute to this instability and the grown the main one of the main one. I'm saying. It's now growing sensibility to new environmental factors and informational influence and intolerance to cognitive loads. It's especially for many young people. So our study was conducted during 2.5 years. It just the last was we checked just some at spring, this year spring. And respondents were young people from 17 to 25. So the result obtained from the study of the level of satisfaction, of life satisfaction, with which was one of the main parameters of our research, so that the majority of young people generally have a positive attitude towards the future. It's a good fact. But the bad factor is that almost 17 are not satisfied with this, their emotion state, and they don't predict its environment improvement. And the same number thinks that changes in future will be rather negative. So you see nearly 1/3 of respondents don't think that the future will be light. During 2 years, these results didn't change. But at the same time, the number of people who believe that changes will go in positive direction has raised significantly. Of course, it's only 13%, but it raised from 2 to 13. So it's a progress for these conditions. But all these materials show that real situation is not understandable for our respondents, for our young people, the majority of our young people, and they can't predict and understand their future. Then it was the results of informational identity. It's the identity, how we measured what predominantly two styles of using and perceiving the information. It's diffuse style, 45%, and informational, 33%. You see, and the level of normative style was only 20. But at the end of the 24, not end, at spring of 24 years, this results a little bit change. The level of informational style did not change. You see, informational style, it's the style where people can check and classify information, which is going through information flow. And it's the best, as we supposed, for the such unpredictable society. The level of diffuse style raised to nearly half of respondents, and the level of normative style decreased. It's the level, the decrease of normative style is good, and I will say further what we are thinking about the diffuse style. In the style when the people can quickly see the information which is very important just now in this very moment, not the very it's relevant only just for this second maybe. And what is very good, that the level of commitment scale also grows. The commitment scale shows that people are going to use this very informational style. the fact that more than half of respondents prefer the diffuse style is likely related to the constantly changing situation. And such a situation requires, of course, adaptation. So they intend to search the information, yes, as I said, specific for a given moment. And so we assume that in this kind of context, diffuse style may be regarded as a way of coping, which helps to adapt to unpredictable situation. And I say it is right assume. So then it was the correlation between results of the informational identity and they have the direct and inverse relationships with life satisfaction scale. And it was the very interesting results because the normative style has a direct proportional relations with the scale of life satisfaction. So the people who don't want, just deny the new information and want to see only what they see, they link them to their past. They have a good level of life satisfaction. And the diffuse style and informational style have inverse proportions with life satisfaction, but only a weak degree of significance. So we can say that diffuse style normative style does not reduce life satisfaction, but it's perhaps to that fact that respondents don't look for anything new or particularly alarming. It's the main question, the particularly alarming, so their emotional state does not regress. On contrary, the informational and diffuse styles can bring the necessary information, but this necessary information very often can be alarming and so reduce the level of life satisfaction. Here you can see that results show that the most correlations are with self potential for being a new and commitment scale. I will say a little bit more about this. Is it maybe seen? So we can see the belief and the ability for self-changes and their correlation with normative and diffuse scale. And it's interesting results that because we can see that belief, it's just the factor of conscious of the possibility for everybody to change. The beliefs does not contradict implicit representations of the person. So they even can be with normative style. So they have direct correlation. The other sphere of assumed concept of person, such as possibilities change the character and behavior during their life, is directly connected with the normative and diffuse style of identity. But we can see that inverse correlation with ability. And the people who predominantly follow these styles, normative and diffuse, do not have the ability for self-change. There is no motivation for self-change, which sharply reduces the potential for some self-changes. So these styles of identity, as I say, have inverse relationships. This picture shows the rigidity of people with normative and diffuse style, and the absence and of will, maybe, and motivation and will to change. The new different picture is with informational side. So the potential, as I say, with for self changes with diffuse style are inverse, but with informational style is direct. And the ability to change with for people with informational style of identity also direct. So we can see that the differences between informational and diffuse style is especially clear when comparing with ability and the will to change. People with informational style have positive potential for self-change. They have motivation, they need, and ability to change if it is necessary in transformed life conditions. On the contrary, people with diffuse style show negative correlation. This we think that it not they not capable to like the people with normative style to change themselves, and we think this it apparently is not only the rigidity but also the lack of cognitive potential. And I hope that in future we will check also the cognitive level and absence of cognitive load. So for informational style of identity, it reflects the person's attitude to information flow, their ability and willingness to negativate the multitude of information and all information, I must say, which they will see, will find in the internet. And it turned to express a high level of social awareness. Of course, they see all information and they classify all information. The diffuse style of informational identity can also easily adapt to non-clear and non-fragile world. And because this information, just the relevant for this moment, may be relevant for future also. So they adapt in a stable world, but they can't quickly navigate the new information, and this decrease adaptation in not stable world. But it's only informational style of identity can help to navigate all the flow, as I say. But at the same time, the immersion in information flow with high sensitivity to informational influence also often leads to decrease of informational output because information is very different. So we can say it's just the result. The impact of changing world is manifested primarily in a low level of life satisfaction. It's, of course, a very negative conclusion, but it's alas true. The desire to overcome the negative influence of instability, both emotional and financial, is revealed not only the level, not high level of life satisfaction, but also in not positive, I must say, expectations about the future. The instability of selectivity percept or classify new information can contribute to life satisfaction in a stable society, as I said, but significantly hinder emotional well-being in a volatile and uncertain world. In this situation, only good is style of informational identity sometimes, but orientation in informational has an ambivalent connotation. On one hand, it helps not to see changes, while emotion stability and emotion and awareness decrease. On the other hand, the style of informational identity helps to search the adequate information relevant to new situation. But as I say, I'm just repeating and repeating because you see, not any of informational styles can be regarded as best. They have, all of them have good and bad sides. The main factor of personal stability is prominent to the chosen style of informational identity. It confirms that about the importance of internal motivation in obtaining fulfilling life. The informational style of identity is directly connected with the need for self-change, and so they help to change in a new world. The obtained empiric data made it possible to identify an important fact associated with different styles of informational identity. Their structure linking to the potential of self-changing with the informational style of identity allows people quickly and adequately identify new information that is important for a person. But as obtained material shows, are not always ensure satisfaction with life. On the contrary, the review style is just all these styles, I must say, the whole construction. This diffuse style allows to respond quickly to the new environment, but it does not help to adaptate in for a given person to new situation. The only good factor for normative style is that it does not decrease the emotional comfort, but not forever, I must say. So it is important to emphasize that all variables are related to working with information, forming a holistic structure that determine the navigation, behavior, and emotional state of users in the network. A high level of commitment to one's styles of informational identity proves that this skill is becoming one of the personality traits and not just one of the types of informational activity. So thank you for attention. If you have questions, I'm ready to answer.
Thank you, Dr. Tatiana, once again for the presentation. So, any question for Tatiana?
I just want to stop here to make sure you can hear me.
Yes, you are audible.
Okay, thank you so much. And I do want to make a statement that I'm originally from the Middle East, and this study has to do with adolescents and mindset single session interventions, culturally acceptable and effective in improving mental health in Arabic adolescents. And so the essence of the research study has to do with a concept that was made popular at the end of the 80s, beginning of the 90s, and that concept is called implicit theories. The concept was made popular by Dr. Carol Dweck, a faculty at Stanford University. She wrote a few books on that concept. That concept stems from her research on attribution theories and motivation that she has conducted for years prior to proposing the concept of implicit theories. Her original work on implicit theories had to do with intelligence, and so the concept is called implicit theories of intelligence. Implicit theories of intelligence imply that people have beliefs that are implicit, so maybe not conscious or we're not necessarily aware of those beliefs, but they're beliefs about our own intelligence. So individuals have beliefs about their own intelligence, and their beliefs can be somewhere on a spectrum where one end of the spectrum, their beliefs of their intelligence are fixed, and then the other end of the spectrum, their beliefs of their intelligence are growth. So someone who has a fixed belief of their intelligence would see their intelligence as stagnant, which you would see here with this character in the purple shirt. And so basically, I'm born with my capability when it comes to my intelligence, and it cannot grow, it cannot change. On the other end of the spectrum are people like this female character with the pink shirt, where their belief of their intelligence is that it's subject to growth, and you're not stuck with the amount of intelligence you're born with. Your intelligence is malleable, and you can increase it through effort and perseverance. So if you look to the right of the screen, then you'll see what research has proposed about individuals with a fixed mindset about their intelligence in red, and individuals with a growth mindset about their intelligence in green. And that pertains to it is about their beliefs about their intelligence, but it affects how they perceive their skills, their challenges, their effort, and what they get from feedback. And it is very obvious now, after I explain all of that, that it is more healthy to have a growth mindset of intelligence, where you do see your skills as coming from hard work, and you have an ambition or a desire to improve. You do welcome challenges, and you embrace them and see them as opportunities for growth, and you're persistent. You do not give up. Someone with a fixed mindset of intelligence tend to give up easily in face of challenges. Also, back to growth mindset, they see effort as growth and path to mastery. And when they get feedback, even if it is negative, they still try to see what's useful in that feedback. They try to learn from it, and they reset. They say, okay, this is not time to be defeated, take it personally, or be defensive. Rather, it is time to improve and utilize the inputs. So that is the concept. It's very popularized now, especially in the education system. And so hundreds of studies looked at the benefits academically of having a growth mindset of intelligence. And research was done among college students. So the graph on the top left was done with pre-med students taking a very difficult chemistry course, and found that students that have a growth mindset in the classroom about their intelligence fared better academically in that course than those who had a fixed mindset. My team and I conducted also multiple research in middle school and high school in that age range, and also found the same thing, found that same thing in class grades on science courses, but also language arts courses in middle school and high school were higher on average for students who had a growth mindset compared to those who had a fixed mindset. So the light gray bars are the growth mindset, the dark gray bars are fixed mindset students. And we even looked at standardized testing and found the same thing for reading, for language, that growth mindset is linked or correlated with higher performance in class. So just to summarize what the research has shown so far about growth mindset of intelligence benefit academically, better grades, as I just explained, lower academic stress for those with a growth mindset, constructive coping mechanisms when it comes to stress in the academia, and then benefits disadvantaged students and students at risk. So students from ethnic minorities and students with low socioeconomic status tend to actually benefit the most from having a growth mindset of intelligence. All right, so the research on growth mindset was not only limited to intelligence. In the early 2000s, researchers started looking at the concept of growth mindset applying to other traits than intelligence. And so we looked at growth mindset of personality, growth mindset of thoughts, behavior, emotions, growth mindset of stress. And so if you have a growth mindset of stress, then you see stress as enhancing. So we call that stress is enhancing mindset. That's the growth mindset of stress, and growth mindset of well-being. And I guarantee you that there will be more coming as researchers explore that concept of growth mindset versus fixed mindset. The one area of growth mindset that interested me the most is the growth mindset of personality. So I switched my research from focusing on growth mindset of intelligence and its benefits academically to looking at the growth mindset of personality and its benefits in the mental health area, especially in children and adolescents. This move in my research from growth mindset of intelligence to growth mindset of personality and looking more at mental health rather than academics has been the result of a collaboration with a big name in the field of growth mindset of personality and mental health, and that's Dr. Jessica Schleider, who is a faculty at Northwestern University in Chicago. And so the research I'll be sharing with you today is in collaboration with her. And so research has shown that a growth mindset of personality does also improve academic performance, and we've done some of that research in middle school and high school. But really where the research is flourishing in that area is how growth mindset of personality improves mental health, decreases aggression and vengeance. And to contrast the benefits of a growth mindset of personality, research has looked at the detriments of having a fixed mindset of personality. And with that, you have greater stress, poorer health, and lower grades. So I just want to stop and make sure you understand, because I explained really well what the growth mindset of intelligence looks like, but to explain to you what the growth mindset of personality looks like, it's pretty much the same thing, but take it from intelligence and put it in personality. So basically, people with a growth mindset of personality see their personality as subject to growth, see their personality that it can improve, it can become better. And so when it comes to the mental health aspect of your personality, if you're someone with a growth mindset, you would see that you can overcome the depressive thoughts, you can overcome the stress and anxiety and become a better person, a healthier person. So that is the beauty in having a growth mindset of personality. All right, so Dr. Schleider that I mentioned earlier was a pioneer in utilizing what we call single session interventions. So I do want to bring your attention to few abbreviations. So if you see GM, that refers to growth mindset. And then from now on, when you see SSIs, it means single session interventions. So prior to her initiative in maybe 2020 or so, we were doing growth mindset interventions, which I'll explain in a second, in person, not online. And sometimes we would do them over 7 sessions, sometimes over longer or shorter. And so it was an extensive commitment from the subjects and from the researchers conducting the study. And so we decided that instead of making those interventions more difficult to access, Schleider and her lab decided to put them online in one single session. So one session, some of the sessions are as short as 30 minutes, some are a little bit longer, up to an hour. Online, they're accessible, and anyone can have access to them. They're free of charge, and so that is her initiative. So I do want to make the transition that earlier studies in the field of growth mindset just measured growth mindset and then divided subjects into fixed and growth, and looked at their difference in various variables. But Dr. Schleider and other researchers said, you know what, instead of just measuring growth mindset of intelligence or growth mindset of personality and looking at group differences or correlating it with variables, let's actually manipulate that. Let's teach subjects to have a growth mindset. And that is where the birth of the SSIs happen. And we wanted to make them short, accessible, and free. In Schleider, in her initiative with the SSI, she was really targeting teenagers. As I said, her initiative with SSI started in 2020, and that was right during the pandemic. And she was very aware that a mental health crisis was rising among specifically that group. But of course, the pandemic has affected the mental health of all ages, but she was really focused on that age group. What do we package in a growth mindset single session intervention? Especially if we're talking about growth mindset of personality, the SSIs I'll be talking about that we worked with had to do with the growth mindset of personality. So we explain the growth mindset of personality concept to the subjects. We talk about how the brain is neuroplastic. So as you're changing your way of thinking about your personality, you're also rewiring your brain. We give them testimonials from teenagers their age, and we provide them opportunities to provide their own input on what they learned and advice they have for teens their age. So yeah, here you can see the benefits of some of the benefits I highlighted in gray of GM SSIs. And the research so far, and that's really a combination of 4 years of research so far, has shown that GM of personality SSIs are effective in decreasing depressive symptoms, anxiety symptoms. They also decrease symptoms of self-hate. They decrease hopelessness and increase hope. They increase this perception that I can problem solve, which is also related to the sense of agency and sense of control. They've also been beneficial in decreasing COVID-19 related trauma symptoms and even restrictive eating. And Dr. Schleider has been able to show that some of those effects, beneficial effects of a single session teaching teenagers how to have a growth mindset of personality can be lasting up to 9 months. All right, so why is it important to target children and teenagers? Her research really targets children 10 to 17 years of age. Some of her publications pertain only to teenagers, but in general, she works with that age range. And the one of the reasons why we are targeting that age group is that they have low access to mental health services and low retention rate. Less than 50% of children with depression access treatment, 40 to 60% drop out after 2 sessions, and only 22% of children maintain their treatment after 6 months. And those children/teenagers face barriers, just like other age groups also face barriers in reaching mental health services. So you can look at the barriers here, but one of them that Schleider was aware of is the parents not allowing the children or the teenagers to access therapy or mental health services. All right, so I'm gonna focus now on my research article that we published with Jessica Schleider and her team. And that was a study that we did in Lebanon. So I said I teach at Holy Cross College in Notre Dame, Indiana, but I took a group of students and we went to Lebanon and conducted the study there. And so the study focused on that group age I told you about, of Lebanese and Syrian refugees in Lebanon who have limited access to mental health services. So just a quick note, in Lebanon, the availability of mental health professionals is very low. There's no insurance coverage whatsoever, so therefore people have to pay out of pocket and it can be expensive. But also there's a taboo attached with reaching a mental health therapist. It's a cultural taboo, so families try to avoid that, reaching out for help professionally. And so with that context, the aim of the study was to determine if online growth mindset of personality, SSIs, can improve mental health of children and adolescents in Lebanon, a country affected by war and economic collapse. So we conducted the study in 2022, and that was 2 years following the Beirut explosion that destroyed a huge part of Beirut and affected thousands and thousands of people. So there's already trauma. There's a major trauma with that. There was an economical collapse that was happening during that time that is still happening. And of course, there was war that has taken place on and off for the years prior that people have been traumatized from, but it's even more so now, as you're all aware, that there's an extensive war in Lebanon. So trauma has been like a continuous topic in Lebanon. Also, what you're wondering, why is there, maybe you're wondering, why is there Syrian refugees in Lebanon? Their war started in 2011 in Syria, and we border Syria, and so thousands and thousands of Syrians came to Lebanon as refugees. Lebanon opened the door to them, but that also taxed their economy, so that added to the problem. And there's about 800,000 Syrians in Lebanon. All right, so the hypothesis is that the participation in the growth mindset SSI would result in a decrease of hopelessness and self-hate and an increase in agency and perceived control from pre to post intervention. So the intervention, I'll just go to the design first. The design is a within subject design. And so teenagers were given tablets and were directed to this website, and that is Dr. Schleider's website, and her project, her initiative or project called Project Yes. Yes stands for Youth Empowerment and Support. And this page is available to anyone, so you all can access it. And part of the Project Yes is Project Personality, which it's called Personality because it teaches those children and adolescents to have a growth mindset of personality. And so as part of the research study, we took her Project Personality and we translated it into Arabic. As you can see, it's been translated in multiple languages. And so the Arabic tab is right here. And so when we were in contact with the subjects, we had done the translation and the piloting of the translation and all the hard work in collaboration with the professionals in the field in Lebanon. And so prior to our arrival, that was all set. So when we got to the subjects, we directed them to click on the Arabic tab for the intervention. The intervention, once they click on that link, gets them to answer demographic questions, answer the ACE questionnaire, which I'm sure a lot of you are familiar with it, which measures childhood adverse experiences, measure a screening test for depression, that's mood and feeling questionnaire, a hopelessness test, a hope scale, a self-hate scale, and perceived control scale. And then, so this is all baseline data. So this is all pre-intervention. Then they go through the intervention for half an hour, which I described some of its content earlier. And then we measured some of those measures again post-intervention. And there were two measures that we only measured post-intervention, and that's perceived change in hopelessness and problem solving, and program feedback scale to know if they appreciated the program, which is the intervention, or not. All right, so to cover briefly some demographics, I do want to highlight that 2/3 of our sample of 71 subjects, 10 to 17-year-old, were Syrians, and 1/3 were Lebanese. So Syrian refugees, 2/3 and 1/3 Lebanese. About 50%, a little bit more than 50% of them were not born in Lebanon because they were refugees. We had more 14 to 16-year-olds than younger or older. And then about 60% were females. All right, so these were the components of the actual intervention, and I kind of gone through that already, showed you the website and how it was translated in Arabic. We wanted what we call self-guidance, so we did not want to force the students into the intervention. So they had my team, my students, as in like, so we didn't want to force the subjects to participate in the intervention. So my students had multiple activities going on in different rooms, and we invited the subjects to participate in the SSI, but they had a choice to do something else instead. All right, so what did we find? We found that, as I said, this is a within subject study. So comparing pre to post averages, we found that hopelessness did decrease, and that's good. We want hopelessness to decrease. And then the effect size was moderate. It was not strong, but that aligns with previous publications of Dr. Schleider, where she found similar effect sizes. We also found that self-hate decreased, and that's a good thing. And we found that perceived control. Okay, so the question that was asked for perceived control is, the prompt was, I sense that I have lost control over my circumstances. So it was worded negatively, and they answered on a scale of 1 to 5. So lower average on that post is good, because that means that they have a stronger perception of control. So that was good too. So those results were according to our hypotheses. The one variable where we did not see a statistically significant change was agency, which is asked in a question of in terms of hope. We did not see a change in that. In the past, other research has, but in our sample, we had not. We also, as I said, asked them about their perception of the program, of the intervention. And if you look at the light blue and the second shade of blue, that would be the really agree and agree. And you can see that very strong percentages, 80% and more of the subjects enjoyed, so either agree or really agreed that they enjoyed the intervention, understood it, was easy to use, tried their hardest, it was helpful, they would recommend it to a friend, and they agree with the message. So that basically tells us that the GM-SSI that we used was culturally acceptable and feasible. And what you need to know is that there has not been any online interventions translated into Arabic available to Lebanese and Syrian refugees teenagers. So this was the first of its kind. Alrighty, so here's a summary of the outcomes that I have explained some of them. So modest improvement in the variables, the 3 variables that we measured. There was also as I said, we measured ACE at baseline, and further analysis that was done after we published the paper showed that these improvements in their perceived control, hopelessness, and self-hate were stronger for subjects that had at least 1 or 2 indicators of adverse childhood experiences. So the intervention seemed to even help more those who had some form of trauma. That's what ACE measures. We also had 2 questions, if you remember, that we asked at the end, only post-intervention, and they had to do with their perception of problem solving and hope, I guess, if I can say that right. And over 70% of participants felt more hopeful after the intervention, and then more than 75% of the subjects reported improved ability to problem solve after the intervention. And then I showed you the graph showing that they did rate the intervention as feasible, enjoyable, and so on. Previous literature shows a long-term effect of so this is exactly the same intervention that Schleider had used in a publication where she had shown in 9 months long-term effect benefits. And so we did not do any longitudinal measures, but based on her literature and us using exactly the same intervention, we would assume that the benefits, the outcomes of the SSI would be long-term in those children and adolescents in Lebanon. And having seen an improvement, 70%, more than 70% of participants felt more hopeful. Hopelessness had decreased on average, is really a huge factor, because we know that hope and a sense of control, which also their sense of control had improved, is linked to better mental health and cognitive function. So we predict that that is something that our subjects would have benefited from after participating in the intervention. What's happening in Lebanon? Why is this important? When we did the study in 2022, and even more so now, which we're hoping to relaunch the study because of the war that's taking place right now and all the displacement of people and the trauma, is there's an ongoing crisis of mental health in children, adolescents, and all ages, really, in the Middle East, particularly in Lebanon, because of its unstable states. So the research has shown, this is all based on publications by Lebanese psychologists, that there's an alarming high rate of pediatric mental illness in Lebanon. 33% of the children and adolescents have probable depression, 50% the PTSD, and 60% probable anxiety. A third of the adolescents, Lebanese and Syrians equal in Lebanon, suffer from at least one psychiatric disorder. And the problem is they have an alarming high rate of mental illness, but then their rate of accessing mental health professionals is very low. It's only 5 to 6%. So that calls for an urgent intervention that's innovative, that's accessible, and that is the intent of this research. So our intervention provides easily accessible, scalable solution, can help close the gap between the alarming rates of mental illness and the low accessibility to mental health services, and it is free. There's no cost to it. Whereas, if they were seeking mental health professionals, it would be very costly for them. As I said, it's the first Arabic online intervention, and it has potential for long-term impact, and that we do value. The study limitations, we did have a small sample size. We actually started with 100-some participants, but we only analyzed the data from those who answered 95% of the questions or more, and so we end up with 71. We did not screen participants for existing mental health conditions or use of mental health services, and we did not do longitudinal measures. We would, as I said earlier, we would love to conduct this research again, and conducted with long-term follow-up longitudinally, and maybe provide other types of interventions, but also provide those interventions to other communities facing similar challenges, which we did this past spring. We took that intervention to Poland and worked with Polish children and teenagers and Ukrainian refugees, children and teenagers in Poland. We're still in the middle of analyzing that data for publication. And these are the references, and thank you so much. Any questions?
Yes. Thank you so much, Dr. Fox, for the excellent presentation. So any question from the audience side?
And I know that there's an extreme prevalence of children facing abuse and neglect, one way or the other, coming from parental neglect, or one way or the other coming from the community, coming from the environment. And we all know that the environment has such a huge impact on our behavior and our future income. So future outcomes, sorry. So when I went to Tanzania, I was based in Arusha, and I looked at the environment, and I was trying to understand why there's such a high increase of children who are facing emotional abuse, educational abuse, parental abuse, environmental abuse, low socioeconomic exposure. So I took time to really look at what literature is saying on abuse and neglect happening in Africa, specifically in West Africa and East Africa. So a lot of the data will come from, it would also correlate to what's happening in the States as well, trying to give evidence on the high increase in abuse and neglect. So it's on a global scheme, but mainly the paper was written in the atmosphere of what's happening in Tanzania and many African countries. So go ahead. So a brief lookout on child abuse and neglect. So we want to define it as the impact of a child's education has an impact on a child's education performance. Children may face occasional inattention. So when they don't have attention from the community, from their parents, and we look at the impact it has on a child and caregiver interaction, understimulation, severe neglect in family or in an institutional care. And in the context of institutional care, in the African context, we're looking at orphanages where children are placed, so the placement are placed in a home due to the unavailability of their parents, or the unavailability of a sister or a sibling or a caregiver. And so these institutionalized cares they're taken care of by grandmothers or nannies or spiritual figures, spiritual mothers, spiritual fathers, to support their growth. And they can be unsafe environment. However, there are situations where kids have been able to move out of those homes and have fulfilling lives. So they're the two sides of those institutional cares. Children in orphanages, social welfare, and underprivileged homes were parts of many studies due to the increase in low parental support on psychosocial care. And psychosocial care has been there are very limited research on the impact on a child's psychosocial care, specifically in Africa. Areas of impact on child abuse and neglect include the child's brain, family involvement, transition to adulthood, early marriage. So there's a high increase in early marriage, and employment, family disengagement, cognitive impairment, poor mental health, poor education, and high rates of school dropout leading to poor employment. So let's go into the, okay, so a little bit of the background. We all know that early onset of absenteeism of the biological needs impacts a child's brain structure. So a child not having nutrition, a child not having health access, education access, parent access, family access, even the community, lack of access to the environment has a huge impact on their everyday skills. It has a huge increase on the risk of developmental disabilities, and that's what we are finding lately, is that children who experience early onsets of abuse and early onsets of trauma have a high chance of developing one or two developmental disabilities. It could be an intellectual disability, or it could be a neurodevelopmental disability. And we look at the high increase in adverse childhood experiences and exposure to trauma, which leads to abuse and neglect, lack of serve and return interaction. And serve and return is such a huge impact. So the lack of serve and return, where the child and the parent are interacting, that eye contact, or that consistent interaction with the child during the first 1,000 days of a child's life is very, very important. So when children don't have that exposure in their first 1,000 days, it has an impact on their everyday lifestyle and the development of the motor skills, development of the social skills, the development of their cognitive abilities, and we'll look further into that. And in correlation, in the United States, 1 in 7 children experience child abuse and neglect. And there's a limited research on psychological poverty, and we need to look more into why that's happening. And its harm and multiple disadvantages in low-income communities in America. So both demographics looks at the increase in low and middle income countries, and that these are the types of neglect we are looking at. As I said, the occasional inattention, chronic understimulation, severe neglect in family in an institutional setting. An institutional setting in America will be different from the African context, just to make that clear. Okay, so some data on abuse and neglect, and this comes from, I didn't really want to go too further into what's happening in the 2000s. I really kept my research in a small scope. So I looked at 2020, which is where COVID started. So 1,750 children died of abuse and neglect in the United States, and this came from the National Center of Injury and Prevention Control. And during COVID, we know COVID had a huge impact on children. So young children who were born and during COVID, due to the lack of face-to-face interactions and due to the uncertainties, there was such a high rise of children facing abuse and neglect. This is from the Allies, the National Children's Allies. Estimated 1,820 children died from abuse and neglect. And then I continued to look at what data said. A high child mortality rate for boys at 3.0% per 100,000 compared to girls in the African context. And girls are facing child fatalities, facing 2.9 times greater than white children. So Black children, specifically African children, are facing a high rise in child fatality compared to children in the Western culture. When we look at in terms of race, white children, and 3.9 times greater than Hispanic children. a fraction of children are in extreme poverty due to the increase in maltreatment, and we'll look further into maltreatment. And 70% of the poverty line rises from 10% to 15% of the state. So these percentages are very crucial to look into, and we need to think about what early interventions can we put into place for low and middle income families to support in the state of abuse and neglect. And oftentimes they could be neglecting the basic needs, the biological needs of their children unconsciously. So we need to we look into the scientific research. We need to have a back of our minds what type of interventions can we put in place to support our young children. So there's some gaps in research, and these are some of the findings. Limited research on the impact of abuse and neglect on a child's psychosocial well-being and the impact of poverty in low and middle income communities. There are signs. We see that in our communities, like when we go into a neighborhood where there's high rise of violence and guns and guns, and the state of it, the physical state of it, those are signs of abuse and neglect. But when we come into the impact it has on a child's educational, on the child's education, that's where there's limited research. When children go into these educational settings, are they understood? Does a teacher understand why this child is facing low grades, or is unable to come to school all the time, is unable to participate fully, is unable to build social skills? That's where those discrepancies come into place. And limited research on the home state of abuse and neglect. How can we define a home that is in the state of abuse and neglect? How can we define when parents are facing abuse that impacts the child? How can we define that? And that has an impact on the child's suboptimal psychological and physical condition. The state of their clothing, how they socialize with other peers. Are they able to talk about their abuse? Are they able to talk about their neglect? So we need to create those spaces for children to be vulnerable, because children's voices need to be heard. And oftentimes it leads to they getting into the adulthood, and then they talk about the abuse and neglect, and we don't have interventions to support them at that later stage in life. So the first 1,000 days are so important, so we can put in early intervention to support them. And abuse and neglect, it can come from war, it can come from children facing, children coming from refugee homes. So there's a lot to think about when we're defining abuse and neglect. And there's limited research in defining that. Limited research on ways to prevent young children from participating in violence. And violence is a place that is an area that I've been really particular on. How can we understand children facing violence and crime from a global perspective? Because it has children facing long-term crisis as a result of being in harmful, abusive homes and separated families. So as I mentioned, there's the institutionalized care and orphanages in Africa. And it goes a long way to understanding what orphanages and institutionalized care is in Africa. And there are pros and cons to it. When we look at the pros to it, when children are in orphanages and institutionalized care, they get funding from the Western cultures. They get funding from the Western countries, sorry. And so there are benefits to that, but the cons is when they have to reintegrate with their families, their siblings, and their relatives. And that's where we don't have a lot of support for children to reintegrate back to their homes. And many institutionalized care have a huge impact on children's academic because they don't have those resources. And we look at institutionalized cares, and many of the orphanages have schools close to them. So they don't have access to socializing with typically developing peers. And that leads to basic health and economic security. So they don't have access to the local health services, and children experience high exposure to parental absence, specifically father absence, with minimum interaction, impacting the development of the child into adulthood. High increase in chronic and developmental disorders, as I said, that result in health and education, that's coming from the health and education systems. So we also need to figure out, we as in this field, we need to call in people from the health and education system to support children facing abuse and neglect, because oftentimes it's volunteers that are supporting children in abuse and neglect. It doesn't really come from the government. And so the government has a need to put place into supporting our young children, because they're facing food insecurity is high in many institutionalized homes. So I'm going to keep going in terms of talking about the neglect in Africa. And between 500 million and 1.5 billion children worldwide endure some form of violence annually. Around the world, 168 million children are engaged in child labor, while 100 million live or work on the streets. And this is such a huge, it's paramount to our communities that children are facing that. And as I said, the first 1,000 years are so important. So if such a high amount of children are facing child labor, then what does the future hold for our young children? In Africa, 50% of child population is estimated to have experienced or witnessed some form of violence. So violence with their parents, sexual violence. We have girls facing sexual violence, such as men who are predators, and they are silenced until they get to high school or university. Then they get to talk about their sexual exposure. And then again, there's limited interventions for young children facing sexual violence. High prevalence of girls at risk of sexual violence, as I said, such as rape. High prevalence of boys experiencing physical punishment and gang-related violence. And children with disabilities experiencing physical and psychological or sexual violence. And we look at disabilities, children who are nonverbal and children who are verbal. And children who are nonverbal many times many of them don't have the right to speak, because they don't have enough, they're not able to articulate, they don't have enough speech, they're not able to advocate for themselves. So some of the interventions have to come to high increase in advocacy for children with disabilities. In 2019, it was estimated that 21.3% of all of them living in sub-Sahara Africa and Southern Asia are facing some form of abuse and neglect, and also some form of early marriages, and we'll talk about that. And so I did it in 3 steps. So physical abuse, emotional and verbal abuse, and traumatic abuse. So 13% of children experience maltreatment by parents and or caregivers. So we can have caregivers and we can have parents. Preschool children are at a high risk of severe injuries due to physical and child abuse. 45% of child brain injuries result from violence, compared to 5% caused by accidental injury. And the look of emotional and verbal abuse, children from low-income racial families exhibit aggressive behaviors, 45% from their communities, 25% from their childcare, and 70% from aggressive friends. And these aggressive friends have come from long-term impact from the early stages through middle stages through the adolescent stages. So these aggressive behaviors from friends is not just at one stage of development, it's from various stages of development. So it's a combined it's a converted continuum. And so we need to look at how aggressive behaviors are having a long-term impact on children. And in the traumatic abuse, children demonstrate low cognitive abilities and low memory scores and low academic performances. So maltreatment, and how does maltreatment impact our young children and the education in their educational journey or in their educational lifestyle? And these methodologies are very practical, and these methodologies are what I observed during my time in Tanzania and in many African countries. So children in low and middle income families experience maltreatment from caregivers, and they face high risk of cognitive and language development in their primary and secondary education. Children experiencing long-term chronic abuse and neglect are at a high risk of low academic achievement. And when we look at maltreatment, we look at violations, we look at sexual violence, abduction, attacks in schools and in hospitals, feelings of fear and helplessness, impaired physical and mental health, poor social occupational outcomes, sexual and emotional violence. Preschoolers experiencing maltreatment are likely to show developmental delays in language, motor skills, intellectual function, and academic achievement. So that's the executive function being their executive function are deprived. Their executive function are deprived from them due to the impact of abuse and neglect from the parents or from the community as a whole. And infants and toddlers, preschoolers show avoidance, like anxious or atypically attachment relationships with their caregivers. Oops. So child marriages and impact and how it impacts girls' education, impacting girls' education. So child marriage is the world's highest rates of teenage pregnancy. This is from a study from a 2022 literature. Many literatures have seen that in many African countries, a quarter of all many girls, of all girls, are victims of female genital mutilation and mutilation, sorry, that was a typo. Premature pregnancy and childbearing, leading to domestic and sexual subservience is a cause of neglected young girls. Early marriage also contributes to the health needs of the mother and children, and the mother may be affected by HIV and AIDS, while the child suffers from chronic health conditions. And on the left-hand side is a brief graph on the increase of children facing early marriages, and we can see how high in South Asia young children are going through early marriages. However, this is between 2006 and 2010, 2011, 2015. So there's been a drastic change today, but I would say that children in sub-Saharan Africa are still facing child maltreatment. However, due to global organizations and due to many ways due to technology and many ways of educating children, we are seeing improvements on girls attaining education, on girls wanting to obtain secondary school. So there is a high rate of children of adolescents not dealing with abuse and neglect. However, we still need to support young children facing abuse and neglect due to early marriages. So some of the findings I have is between 2004 and 2010, this number declined from 279 million to 249 million in 2010, with the highest prevalence in sub-Saharan Africa. Children under 5 years in low and middle income countries are at a higher risk of not reaching their developmental potential. Black children are overrepresented among maltreatment victims compared to Latino and white children, who are typically underrepresented. Low maternal schooling and child physical abuse by either parent or by caregivers. Children with working mothers and absent fathers are presumed to experience abuse and neglect. And children with two non-working parents or parents whose income is below 75 of the official poverty level are likewise impacted by the abuse and neglect. So I just want to talk about the two non-working parents, and that's really high in many African countries where we still have those gender dominance, where the father has to go and work and achieve and have a land and have a property, and that increases the risk of father absence, and the mother stays home and does her best to provide for the child. So the father works long hours and the mother doesn't work most of the time, doesn't work all the time. Most of the time she doesn't work, or she has to be on the streets and try to find food to come to provide for the children. Oftentimes, the young children have to go on the streets and perform what we call hawkers, and to get money and come home and support the child. And usually we find girls going on the streets to get money one way or the other, sell food on the streets to come home and provide for the family. And while the boys will go to school or have a higher potential of developing motor skills or developing cognitive skills or social skills, while the girls have to go on the streets and work, and which is really sad that we have our young girls do that. So there still needs to be intervention into that. So as a result, there are more schools. More schools need to be responsive to meet the needs of children by educating teachers, support children during exposure to abuse and neglect. Teachers and educational administrators must be accountable for the physical and emotional well-being of students, regardless of their disability, economic status, and/or gender identity. A child's disability does not mean they are not able to advocate for themselves. They still need to talk about what they're facing. Signs of abuse and neglect can be a reflection of both the caregivers and educators when both don't talk about a child facing abuse and neglect. Greater emphasis must be applied to child-initiated, teacher-supported learning and experiences for positive and healthy zones of proximal development. And health sectors need to take global initiatives to ensure children facing abuse and neglect have access to medical and health services. And what I would want to talk about in terms of the last part is the global initiatives, the global parent initiatives that has been doing a great job at including global parent issues in many webinars and in many training platforms to talk about how much fathers need to be part of the lives of children. And recently, there's been a talk on the first 1,000 days and the next 1,000 days and the second 1,000 days. So we need to be part of these conversations to advocate for our children on how much we need to support them medically and educational wise. And I just want to I also want to emphasize that in terms of education, children are having a hard time, understanding math, understanding English, understanding many girls are not going into many girls are going into the STEM, but it's mostly in the Western side. However, we are still seeing we're seeing girls going into the STEM fields, but we need to advocate more for children to be in the STEM field so that they understand what it is like to own educational leadership. That's what I want to also emphasize on. So what are some action plans? And I spoke a little bit of that. Its caregivers and educators must reciprocate and nurture rich experiences that create outdoor opportunities for children to build a solid foundation in learning. And when we look at reciprocating and nurturing rich experiences in our classroom environment, how do we demonstrate healthy learning? How do we provocate learning spaces, not just about academics, but in play-based learning? When we demonstrate play-based learning for young children, they're able to know what is healthy and what is not healthy. And so when they go into their homes and they are exposed to violence or abuse, they are able to advocate for themselves because they're in a learning space that is healthy and is reciprocated. Employing educational programs that encourage and empower youth to be in a school to gain independence. And that's the goal for our young children, is that we want them to be independent. We want them to have educational and leadership skills. We want to advocate for the voices of young children and abuses and neglected homes through community building and youth workshops. These are some of the interventions we can keep in mind. How do we build community capital? How do we support them in these spaces? Advocating for parent workshops. Parents also need interventions because they are the primary caregivers of our young children. For them to feel a sense of community and belonging, to take ownership of their mental, physical, and marital well-being. Improving research to understand unknown percentage of children in harm is also a place that we can look into supporting young children and expanding on those gaps. So this is a bit of the reference, and this is my email. If you have any questions, I will be free to answer those questions. And thank you so much for inviting me to speak on abuse and neglect. And it's an ongoing research. I'm still looking into the prevalence of abuse and neglect. However, I am willingly to have other expertise in the field. I am still learning, and so you're still invited to let me know what is going on in your country and what is in terms of abuse and neglect and what the prevalence is, and we can definitely collaborate and try to have more interventions. I think early childhood interventions is what we need to increase to support our young children. So thank you very much. And I'm open for any questions.
So thank you, Afia, for the presentation. So any questions from the audience side?
To a spiritual core within people, explain this framework as a foundation for an applied spirituality. Breaking news, we can now intentionally promote spiritual awakening and experience without drugs, not using psychedelics. And it all begins with this. Let me see if I can remove my video panel. Okay. There is an unseen order. William James describes an unseen order where one has to characterize the life of religion in the broadest and most general terms possible. One might say that it consists of the belief that there is an unseen order and that our supreme good lies in harmoniously adjusting ourselves thereto. This belief and this adjustment are the religious attitude in the soul. And William James uses the word religious the way I will be using the word spiritual. Years, there was an unseen order in objective world, until Sir Isaac Newton identified the laws of gravitation and motion. Well, there is also an unseen order in subjective experience. This is the framework that we will be going over in some detail, beginning with the cognitive behavioral focus on thoughts, feelings, and actions, progressing to experiences of self-worth, dignity, and we'll talk about the final part of the table. Let me initially start. When I'm using the word religion, we're really talking about institutional aspect of beliefs and practices related to a social group, where spirituality is a dimension of personal human experience related to the sacred or ultimate reality. What do I mean by spiritual experience? Now, we use the word spirituality in a broad sense. I'm going to be talking, this is a definition. In a big sense, the quality of the relationship to whomever or whatever is most important in life. Several things, it's a quality, it's real, but it's ineffable, hard to put into words. It is a relationship. It is not a thing to have or do. And it is related to the most important or supreme things in life. And when we look at spirituality and spiritual experience, there are certain characteristics, and these are not totally inclusive, but there is a connection with something beyond our usual experience. There is a vitality that wasn't there 2 minutes before the experience. There's a sense of wholeness or integrity. There's usually an emotional reaction of some sort of peace or serenity. And there's usually a meaning or purpose. Now, we use spirituality in a global sense that may have these characteristics, but a particular spiritual experience has these in a way that we may refer to as mystical. I will say from the beginning, I'm going to be presenting the theory. We tested it out in a study, in a manualized group therapy, 10 1.5-hour sessions weekly. Residential addiction treatment, men with repeated addiction, incarceration averaged about 4 years, with measures of mystical, spiritual experiences, well-being, worthiness, existential connection, and universality. 14 out of 15 men, it was a pilot study, self-reported a very strong or extreme spiritual experience, and the total scores on all measures showed a significant intervention. These are the measures we used, and you can see the p-values are quite study, and this is without drugs, compares to some of the psychedelic. Comments of participants, I'll just read a few because we're running some late. There was one point at which my hairs on my arms stood up and felt a total experience. My entire look on life changed. I now feel like I'm here for a reason and I have the potential to do everything I need to do. Thoughts of calm, understanding, acceptance. I got the purpose I was looking for. I learned that God will be there for me through everything, and I believe I have a purpose in life now. I have finally found peace within. It was a very dramatic change. When I use the word spiritual, what we're talking about often occurs with mystical experiences. So spiritual, mystical, and numinous may all be synonyms. What we're talking about is a non-ordinary experience, different than usual life. There may be an ecstatic mood, a sense of new knowledge, perceptual alterations, including hallucinations, delusions with themes often related to mythology or religious traditions, and there is an absence of conceptual, absence of cognitive disabilities or deficits. There is an absence of suicidal or homicidal ideation. There is a frequent misdiagnosis as medical or mental disorders. A spiritual experience may progress to a spiritual crisis or emergency, including psychotic symptoms, when someone doesn't even understand what's happening. And all of this leads to a missed opportunity for growth. These are some that may be associated with true spiritual, religious experiences and not mental disorders. Neuroscience, we now with fMRIs have the ability to identify regions of the brain that are related to mystical experiences, as superior parietal lobes, temporal parietal junction, with peak experiences and feeling of unity. The medial prefrontal cortex associated with mystical states, the inferior parietal lobe with a sense of self and self-awareness. And keep in mind in the future, look at the default mode network. This is a network including the medial prefrontal cortex, the posterior cingulate cortex, the hippocampus, and the inferior parietal lobe that functions as a hub. It is a global brain activity pattern. And it's like this: cortical and self-awareness. It is a network. It is homeostatic. An unknown sigma as an additional awareness of our abilities and memories. We begin with cognitive behavior therapy. There are sensations that we have, and then there are perceptions. Perceptions that we have thoughts, we have feelings, we have actions, with the next level being conceptions. We have beliefs, values, habits, and practices. And this is the area where religious identity. Almost every discussion you have about religion will use words of beliefs, values, and practices. However, this will not get us into spiritual experience. Spiritual integration of all three into a domain of being, and we capture this with the word attitude. Attitude is an integration of a thought, a feeling, an action. For instance, a pessimistic attitude has a thought, it's not going to work out, a feeling of disappointment, maybe doubt, and an action of being closed, dismissing, discounting, or even avoiding. One of the major attitudes that is present, at least in the American culture, is the idea that I am what I feel. If I feel sad, I am sad. If I feel guilty, I am guilty. And this is one of the first attitudes we work with, because these attitudes, well, what we move toward is an attitude of you are not what you feel. You have feelings, you have thoughts, you have behaviors, and we have an ability to decide which of those we empower. In our work, we're recognizing that this is what is meant by the veil of illusion, because attitudes are out of awareness. And it's the veil of illusion in Eastern traditions that keeps our conscious awareness from the rest of our being. The foundation of this is the triune brain theory by Paul MacLean. Real quickly, there are at least three parts of the brain that we believe are related to three different stages in human evolution. The brain stem, unconscious, automatic, fight, flight, freeze, fawn, survival, physical aspects of being. Then we have the mammal brain, primarily the limbic system, where we have three things: emotions, memories, and it does make decisions. And the neocortex, which is the human cortex, which is primarily language and reason. The problem is we literally have two brain processors working simultaneously, and they're not well connected. There is a fast, unconscious, non-rational, different learning, older, probably limbic, a slow, conscious, rule-based, rational, probably newer, human. And because the older system acts first, it can make a decision that the awareness, our cognition as a human isn't aware. So the human condition actually looks like this. Something happens, the limbic brain reacts fast, makes an irrational decision. Do you ever wonder Why would an 8-year-old that's physically or sexually assaulted for no reason of her own come up with a decision? I am a failure. I am worthless. I should be dead. It's irrational. It's our animal brain making the decision. The cortex has no awareness, but that decision controls their actions with depression, anxiety, and all of the PTSD symptoms. And the cortex has no awareness of this, but it has to come up with some explanation for why are all these things happening. So it tries to adapt by changing behaviors, defense mechanisms, drugs, money, power, rituals, beliefs, anything that will compensate for the injury that is not yet recognized. There are two main experiences to get us into this: the spiritual language of self-worth and dignity. Attitudes come from effects on self-worth and dignity throughout our life. So let's look at these. Beginning with a definition, that quality, again, ineffable, of a purpose, of a person or thing that lends importance, value, merit, that is measurable by the esteem in which the person or thing is held. Self-worth develops over time, beginning with action, self-confidence, progressing to feelings, self-esteem, thoughts, self-confidence, when the brain myelinates at age 5 to 7 and only becomes integrated as self-worth pre-adolescent. Shame isn't just a feeling, it is the total being impact of feeling and being unworthy. Dignity, a word we don't use and a word everywhere in the world is probably misused. First of all, they mix worth and dignity. The definition, the quality of being worthy of esteem or honor. This shows that worth and dignity are related, but they are not the same. Dignity is not an noun. It is not something we have. We use dignity as an expression of being, and the focus is on honor. And when we look at what is it that we honor most in the area of thinking as a human being, it is reason. Beginning with making choices with reason, not with feelings, not with habit, not with copying or modeling after others. And with practice, socially, it becomes wisdom. In the area of feelings, what we honor most about being human is compassion, asked the Dalai Lama, beginning with our incredible capacity for empathy because of language and mirror neurons, progressing socially to caring and eventually justice. And in the domain area of courage, doing what we honor most is courage. With our knowledge of knowing the risks, and we still may even risk our life. Beginning with honesty with self and others, the foundation of social reality. So when we strengthen self-worth and dignity, something happens. It spontaneously opens a spiritual core. We now have to add another arrow with the psychedelics. Psychedelics open this spiritual experience. And when you look at any of the psychotherapeutic processing of psychedelic experiences, you end up with an increased worth and dignity. I already went through some of the mystical signs of the spiritual core. These happen when it opens. That's an explanation for why we have mystical experiences. What's really happening is this. When we strengthen our core self-worth and dignity, it opens another dimension, what we call the creative forces or creative openings, because they're powerful. And the first one that usually opens is love. And this is not love as an emotion, not love as a commitment like I love you, but love, the agape, the love of God, the divine, unconditional love of the world. In the area of thought, what opens is truth. There's not truth like right or wrong, good or bad. Mahatma Gandhi talks about the satyagraha, a moral truth force that is embedded within our whole being, recognizing when someone's worth and dignity are being injured. And finally, in the area of action, what opens is faith. And this is not faith like a belief. This is faith as an action. Moral core truth, unconditional love, and an indomitable faith. If you look at those three things, you have the major core of what we refer to as a functional soul. This is a language that gets to the level of soul, the level of spirit, and can be very healing. And what do we mean by faith? Taking that leap across a chasm with no guarantee that you even get to the other side or what's on the other side. And this is how powerful we think this is. So what happens, the limbic system is always trying to say, wake up and fix me. The conscious brain interprets it as anxiety, too much, it's suppressed. With mindful meditation, we go back and reconnect with our lost parts of our heart and soul that have been broken off, recall the feelings and memories with no judgment. Judgment is the problem. We lead to acceptance with self-compassion, forgiveness, and when this is done, the suffering goes away. The mammal brain extinguishes, it deconditions the suffering. How do we know? Gratitude and peace open, and there's an enhanced self-worth and dignity. If you want to know more, you can look. These are writings that have been done describing this, and I will leave you with a quote. Reason without compassion is heartless. Compassion without reason is directionless. And reason and compassion without courage is feckless, totally helpless and incompetent. So neither one, reason, compassion, or courage, will get us the human flourishing we need. It must be all three. It must be the quality and expression of human dignity. So we have the unseen order using dignity, reason, compassion, and courage to strengthen our self-confidence, self-esteem, self-competence, opening this spiritual core, which is a holotropic system. So thank you very much, and I will stop sharing and see how I can get on my Zoom. Okay. Okay, thank you. And
Thank you,
I know
Dr.
we're
Calvin.
over time, so we may not have time for questions. My email is in the chat.
Okay.
Okay.
Thank you again for the presentation, Dr. Calvin.
Thank
fast, but hopefully there will be time for questions or people can reach out via email. Wanted to point out really quickly who the people were behind developing this resource, our starting point, our goals, what the fun exchange is, and then a reflection of the resource itself and where it stands right now. So in 2020, there was a conference that we attended to, and this was through the Faculty of Undergraduate Neuroscience, and there were about 64 people at first, and then there were 12, and then Dr. Michael Wright and I remained, who essentially put this resource together. He was teaching at the California State University in Sacramento prior to the pandemic. He had only been teaching face-to-face courses related to neuroscience, so no online at all, and I am teaching at Utah Valley University, and prior to the pandemic, starting in 2020, I had only been teaching face-to-face classes, and I only ever taught one section of psychopharmacology. So neither of us were experts in anything online, teaching online, doing activities online, and so forth. However, because we had to pivot with the pandemic, I wanted to share a couple of things why this initiative actually started. So in spring 2020, if you remember, or if you don't want to remember, I'm sorry if I'm bringing this back up, but 91% of the faculty had to transition a course or multiple courses to emergency online teaching. Okay, which was a completely unheard kind of scenario. And by fall of 2020, the epidemic continued, and 2/3 of the faculty fully taught online. And 1/4 of the faculty taught hybrid with a flexible format. So meaning lots of people teaching neuroscience had to pivot and teach online classes for neuroscience classes that haven't been taught online before. And so ultimately, 76% of the faculty in total had to adjust the course modality. So again, if you're thinking about some of those neuroscience concepts, if you're thinking about teaching neuroscience, many of the things are hands-on. And so what we were looking for is some kind of idea on how can we teach neuroscience online, and how can we teach neuroscience online well. And so when you're thinking about, okay, I need to come up with an activity and I have to find a resource that I want to enhance my teaching with, there is essentially these common steps that we envisioned that people are going through. So if you're looking for activity or resource, right, you want a specific type of resource related to a specific topic. And this is all before AI rolled out. People would be using Google, or maybe they're checking an existing resource. So maybe case studies in pharmacology or QEPs, any of those kind of things. And so if you were lucky, right, it would provide you with something like I'm showing here, right? You might come across some kind of case studies. Maybe if you're lucky, you might even find an answer key. The problem with that kind of system was that it was very, very difficult to actually vet those resources, because if you did get lucky and find anything, you couldn't actually really easily identify who the author of that resource was, whether it would apply, what kind of level for students it would be targeted for. Is this for master's students? Is this for intro-level students? Is this for students in an upper division course? Those different kinds of things. And so when we met, we were trying to figure out as a group on what are resources that we can use to teach neuroscience virtually. Obviously, now that we have moved on from the pandemic, right, the idea is we have been expanding this, and, you know, are there things that, how can we teach neuroscience, not just virtually, but also in person? But then the other question is, how can we make sure of the quality of those available resources? How can we assess them? And then is there a method of how the author can be contacted? Okay, and so that was our starting point. And so we were trying to look at, you know, are there resources out there that we can base our search on, so that we can help each other, but also help other people in the field of teaching neuroscience. And so we came across a database that was called AARON, and AARON actually has been taken down since, because it was supported by a grant. It's no longer supported, so it has virtually disappeared. I've never seen the resource, but there is a publication in June. June is a journal that publishes things on the teaching of neuroscience. So there's lots of good resources there. I already mentioned QEPs before, but all of these kind of searches and all of these kind of collections have multiple types of limitations. One main one is accessibility. So a lot of those resources are behind a paywall. You have to be a member. Lots of different kinds of issues with that. Some of them are not very searchable, so you can't just put in, okay, I need something for an undergraduate class at a lower level, and so forth. Upkeep, I already pointed this issue out a second ago. AARON was a very useful resource when it existed, but it wasn't upkept because there was no funding available, and so it was taken down. And furthermore, with some of these other resources, if there are any, community members can't actually contribute. And so we had this idea in the school that we wanted to make a resource where we can literally have all different kinds of neuroscience resources to teach neuroscience better in an active, interactive way, whether it is face-to-face or online, that needed to be accessible, it needed to be searchable, it needed to have high quality of resources, and it needed to be community driven. And so we started in 2020 with using Airtable. And at that time, it was completely free of charge. It wasn't tied to any organization or membership. And it allowed us to have unlimited access on how many people were editing the resources, how many people were essentially contributing actively or just viewing the resources. And so when we established Airtable, what we then were looking for is we wanted to create something that is completely searchable with all of the different kinds of topics in mind that anybody who is teaching anything related to neuroscience might be interested in. So we broke up the resource into different types of topics, and I'll show you this in a second. Hopefully it'll work. We'll see. But focusing on, for example, things that are not just exams, on how to assess learning and understanding from students, case studies, class activities, so things that you can actively do in the classroom, specific information about lab equipment and supplies, meaning if you're new to teaching neuroscience, even on a low budget, where can you go? What kind of resources can you use that might be low budget, right? Where can you get the supplies from? We were looking at lab exercises. There are some pieces of information that have to do with media, so specific movies or specific books that relate with neuroscience. We had started with entering information about open educational resources, anything that had to do with podcasts, simulation activities, and so forth. Furthermore, we wanted to make sure that within neuroscience, because neuroscience is so broad, that we can also tag specific type of subject areas, such as introduction to brain and behavior, which would be very different than if you're teaching a class on behavioral neuroscience, or if you're teaching a class on psychopharmacology or sensation and perception. We also wanted to make sure that keywords can be searched within that database. So just as a couple of examples, maybe you're interested in specifically anything that relates with neuroanatomy, or maybe anything that relates with memory or with aphasia. And so we wanted to create essentially a database where we can search through all of those. Also, because some of these resources that you can find, if you came across any of them using Google, now you can use AI, but we really wanted to have the link back to the contributor as well. We wanted to have a means of where a person might be able to look into how long the activity is. And so I'm going to try, I don't know yet how to do that. I'm going to try to see if I can. I'm going to stop sharing. That might make the most sense, and then reshare, but hopefully I'm going to be able to share. Let's see, I'm going to try if we can go to Airtable. All right, can you see the internet window that I'm in? Yes, getting any responses?
Yes, it is.
Okay, perfect. So this is what the Airtable looks at this moment, okay? And so it looks like a kind of a fancy Google sheet, if you may. And so we have specific tabs on the top that are organized based on the topics that I have pointed out. So beyond exams, case studies, class activities, lab equipment and supplies, and so forth. And I just wanted to share with you really quickly, just as a just as an example, we have over 450 entries in all of these tabs across, okay? And if you're just beyond exams, so those would be kind of things that have to do with assessing student knowledge, but that is not based on exams, meaning you could ask the student to write a haiku or maybe create an infographic. And so what we have done is that each one of these entries has a description. So you can click on a description, you can figure out what this is all about. The subject area, we have linked with specific keywords. So where it says adaptable, this would be working for any type of topic. Some of them are specific to psychopharmacology. If we go further over, we have linked this with keywords. We have also made a notification on whether this would be suitable for lower or upper division courses, if this is inside or outside the class. And so those are assessments that the student would be doing outside of class. So this is not an in-class activity. And then we have specific attachments linked. So we have these attachments linked that essentially tell about the activity, maybe what kind of grading rubric there is, what kind of activity there is, okay? And then we have linked over here the author's name, okay? And the important thing here was that what we envisioned is that when you have this author's name over here, you could go back to the contributor information and figure out, okay, this specific activity came from this person, and then you can figure out, okay, this person teaches at this university, this is the email address, this is what kind of activities they contributed. So if you can go across, you can see that there's multiple entries for some of the authors, but we have a direct means of contacting those individuals. Again, just to show you another kind of scenario, for example, if we go under class activities, for example, there are some class activities that can be run inside the classroom. There's specific subject areas where it would be suitable. Again, we have these activities linked. We have a specific web link if there was a publication that went with it. We have the time requirements, so you could actually toggle up and down on how long this activity takes. So if you're looking for a shorter activity, you can look at some of the shorter activities and so forth. And so we envisioned that this was going to be a very useful resource. I'm going to go back to where we were. Let me see if I can, without unsharing and resharing, let me see. Just have to find the correct place. Okay, oopsies. All right, can you see the PowerPoint, or is it still on the Fun Exchange?
No, we cannot see the PowerPoint. It is
Okay,
still
let me, I will have to go back and unshare. That is silly. Stop sharing. Okay, and we're going to go to share again, and we're going to go to this and click share. Okay, sorry that the jumping back and forth didn't work very well. Okay, so with that being said, when we were thinking about creating this resource, we essentially we envisioned that if you need a specific resource, right, you can proceed to the Fun Exchange and you can find the specific tab with the type of resource that you're looking for. And then the vetting could happen by you looking over the resource that is there, by looking at the attachments of those documents that we have, or you could email the contributor it directly. Now, with that being said, we were really hoping, right, to have it accessible, searchable, high quality resources and community driven. However, the caveat that I wanted to point out is that when we started with Airtable, it was completely free. Nothing was behind a paywall, and we have currently there's over 180 individuals who are actually having viewing rights to the resource. But over the last year and a half, I've been watching that Airtable has been moving more and more things behind a paywall. And so I have been looking at other things on where to move the resource database to, so that we don't lose the community-driven component. Because right now, even though we have 185 individuals who can see and view the resources, there's only 2 editors. So we can't actually add anybody to the Airtable who wants to contribute. And so I am currently in the process of switching everything over to what will be Google Sheets, because since we started with Airtable, Google Sheets has been updating their system, and we now can have attachments. And so I'm in the process of rolling everything over. So the resources will all be there, but it'll take some time until I can make this go live again, because again, I have to convert all of the resources that are in Airtable to go over to Google Sheets. The only restriction is that you have to have a Google account. Again, it is completely free. I'm not hoping that that will go behind a paywall. But with that being said, I'm still hoping that as we go forward, that it can stay fully accessible, searchable, high quality resources, and that it can be community driven. So right now, Airtable still exists. I will slowly migrate everything over. And then once it's migrated over, I'll put the Google Sheets live. And so again, if you have any questions, I have my email on the bottom. I will also type it in the chat in just 1 second, but I wanted to really thank the organizers of the 4th International Webinar on Neuroscience and Psychiatry for me to be able to present on this, because again, the more people know about this, the more people can contribute, the more people can share their resources to really help teach neuroscience in an interactive, engaging way, because this will also not just help the faculty member who's teaching, but it will also obviously help the students who are learning about neuroscience be excited about the field, be excited about learning, being able to apply the material better. And so we're really helping that next generation move forward in the field as well. And with that, I'm going to stop sharing and then type my email in the chat. And then I don't know if we have any time for questions, but I tried to make up time because we were behind.
Thank you so much, Dr. Claudia, for the wonderful presentation with an explanation. So any queries from the audience side?
Other psychopathologies and then to see are there ways to reply to the objection. Philosophers, and just like everybody probably, are sort of fascinated by a lot of these very strange psychopathologies. Really hard to understand some, and have been writing about them for many years, even if you go back to John Locke hundreds of years ago. He's describing things that sound like, dissociative identity disorder and other things like that. So, and not to mention even just straight amnesia questions. So sometimes there seems to be almost contradictions involved. If you're not familiar with Cotard syndrome, sometimes it's described as falling in the general category of depersonalization disorders. It's one of many, which I guess generally could be described as like a feeling disconnected with yourself or the world around you in some sense. Specifically, Cotard patients have the delusional belief that they're dead, either figuratively or literally, do not exist, putrefying, have lost their blood or internal organs. It's very strange, obviously. And even if you just think of the sentence, someone might, if someone said, I am dead, what could that even mean? Not to mention what seems to be a irrationality about it. What do you mean you're dead? Who's dead? The person's going to say me, and that doesn't seem to make any sense, right? And there are other disorders like this. It is often accompanied by depression and anxiety, which, no one's really 100% clear whether they just co-occur or one comes first or whatever. But I would imagine it would be kind of depressing and anxiety-filled if you had this anyway. And in terms of the brain areas, at least the most common that are the lesions you find in the parietal lobe, which, makes sense for various reasons. Self-awareness sometimes is described as having those areas as the main location of it. If you want to look at a few quotes, here are some quotes from practitioners, sort of like quoting some of their patients. And they would say things like this, which is very strange. She had the constant experience of having no identity or self and being a body without content, convinced that her brain had vanished, disappeared, and so on. Her whole body was translucent. It's hard to know what to make of it, so many times. If you think about, I'm sure most of you are familiar with some of the books, Oliver Sacks, right? You read some of those accounts and you just sort of think, this just sounds like it's impossible or it's completely nuts, right? And you get a lot of these kinds of quotes, right? I am no longer alive, I'm dead. I speak, I breathe, I eat, but I'm dead. Sometimes I am a ghost, or I'm dead. Denying that there's, that they have blood, that sort of thing, right? And so it's really hard to know what to make of these sorts of things and to try to explain them. And of course, there does seem to be an element of irrationality to them. The reason I bring it up in the context of I guess you'd call it a philosophical theory of consciousness is because this theory requires basically that when you have a mental state, you are at least implicitly having the thought that that mental state is yours, right? And so the higher order thought theory, HOT is the abbreviation, requires a higher order thought about one's own mental state to accompany every and each, conscious state. And you can think of it as a form of self-consciousness, self-awareness, something of that type. Maybe the most straightforward way to state the theory, there's a lot more complicated than this, and obviously you can't get into too much, but the HOT theory of consciousness says what makes a mental state a conscious mental state is there is a HOT to the effect that I am in mental state. M, sometimes M is just used as an abbreviation for mental state. So the idea being that when you are in a conscious state, you must at least in some sense be aware that you're in it. Otherwise, it doesn't seem like it even makes a lot of sense for it to be conscious, right? A little more of an elaboration here. Philosophers are typically, of course, one of the things we're interested in is answering the question, what makes an otherwise unconscious state conscious? So just about everybody these days, of course, believes that we have unconscious mental states. But then the question becomes, important question, well, what changes, right? What happens, you might say? How does that unconscious mental state become a conscious mental state? The answer that this theory gives is it becomes conscious when there's a higher order representation, higher order of the mental state. The higher order thought theory, more specifically, says that it's a thought about the mental state, as opposed to like a perception or something else. So my desire to drink some water becomes conscious when I am aware of the desire. Intuitively, if you think of it like this, it seems that conscious states, as opposed to unconscious, are mental states I'm aware of in some sense, right? So this is sometimes referred to as the transitivity principle in the literature. A conscious state is a state whose subject is in some way aware of being in. Conversely, the other intuitive aspect of this is many times people will say, well, the idea I could be having a conscious state while totally unaware of being in that state just seems odd, even contradictory. Mental states of which a subject is completely unaware is clearly an unconscious state. I mean, it almost seems like definitional, right? I mean, what are your unconscious mental states now, the ones that you're not aware of being in? Right? So there's an initial rationale for the theory. There are objections and, articles and books written on that. And so Cotard, and some of these depersonalization disorders sometimes are viewed as you might say, a bit of a problem for hot theory and other theories, right? There are two others I'll mention now too that come up. Somatoparaphrenia is a bizarre delusion characterized by the sense of alienation from parts of one's body. So patients will often deny ownership of a limb or an entire side of their body. So again, Oliver Sacks, for example, described a scenario where, a woman was lying in bed and she was trying to kind of grab her left leg and throw it out of the bed because she said, it's not my leg, that sort of thing. And again, very bizarre, very strange, but it's a disorder and, partly based on the areas of the brain damaged when they get to know more about the person. It might, just like some of these others, it might seem to threaten the viability of the higher order thought theory since it requires a hot about one's own mental state to accompany every state. So in other words, if a mental state is going to be conscious, you got to have a thought that I am in that state. But it looks like in a lot of these cases of these disorders, they're explicitly even sometimes denying, right, that it's theirs. Cotard syndrome might be interpreted in a similar way, at least if you interpret it a certain way. I am dead, like I said, or something like that. There's also thought insertion, right? You typically found in paranoid schizophrenics that some thoughts are not one's own in some sense, or they're being inserted into one's mind by someone else. So many people are familiar with that. Again, it's kind of bizarre, hard to understand, being in that situation and so on. But now, not just a reply from hot theory, but here are a bunch of distinctions that are often made in this area, mostly under the heading of varieties of self-awareness, right? In other words, the idea is first to distinguish various types of self-awareness, and maybe that could help us understand these psychopathologies. I mean, they are kind of strange, and maybe if we make these distinctions, that what looks like a contradiction of a certain sort goes away, disappears, right? So Wittgenstein, last century, well-known philosopher among others, made a distinction between I as a subject, and as opposed to I as an object. What he seemed to have in mind in most cases I as subject was something like I from the first person point of view, whereas I as object is something more like me from a third person point of view, which would have more to do with someone else, say, seeing me, my body, right? Presumably something like my body. And that distinction is kind of important in other ways. He uses example of seeing yourself in the mirror, that kind of thing. There's also a distinction that's used quite a bit is self-awareness of a mental state as opposed to bodily self-awareness. So self-awareness of a mental state would be a mental state which not only may be directed at something outside, right, a perception of something outside you, but also there's a kind of reflexive element. It's aware of itself, whereas bodily self-awareness would be, again, quite different in that respect. Again, it's none of these things were all that simple because you do have, for example, proprioception, right? Like, where does that fall? It's a little ambiguous, right? The other thing that a higher order thought theorist might say, well, that theory is meant to just be a theory of mental state consciousness. It's not meant to be able to try to explain every kind of irrational set of mental states someone has. So sometimes we'll say, well, look, the person has a conscious thought that I am dead. What makes that mental state conscious? It's because there's an awareness of it. Does that mean that the thought is rational, or that the thought doesn't contradict anything else that you might say? I mean, all of us, in a way, no doubt, have some contradictions somewhere in our group of mental states. And so if you distinguish those, maybe the theory isn't in such bad shape. Also, some of the same theorists will say, we want to make sure we're clear about the difference between first order mental states, that is, mental states that are directed outward again, as opposed to introspective or reflective mental states where one's attention is directed internally. And that could help a bit. I'm sure many of you are probably familiar with the historical problem of personal identity. I mean, there's more than the historical, but the philosopher or the person associated most with this problem, at least centuries ago, would be John Locke. And when he was talking about what makes a person the same person over time, that's the way the problem is framed, he basically says, well, it's the psychological continuity someone has, right? So I'm the same person as I was, at a party for about a month ago because I have some memories and my consciousness goes back to that. You don't. So that's kind of continuous with my psychology, and memory plays a large role in it, episodic memory. On the other hand, there's also what I call biological or bodily continuity. And there are some who think, maybe that's even more important. I mean, we are physical organisms and so forth. Sometimes this distinction also plays a major role in the mind-body problem, as it's called. Can the mind exist without the body, right? Is there a life after death question? Obviously, that's a major philosophical topic in its own right. So how does that distinction and those previous distinctions help here? What you can point out is, again, there's a lot of ambiguity of this talk of self-reference and the use of I. So just to give one example, when someone says, I am dead, say a Cotard patient, maybe he just means my body is no longer alive or functioning, or I'm no longer my body, as opposed to I'm no longer conscious, or as opposed to my conscious existence has ceased. So the I in one case might be referring to the body, as another case might be referring to, you might want to say my consciousness. And I mean, it's still bizarre and strange, right? Hard to understand how someone could literally believe that your own body is no longer alive. But that's a separate question, right, in a way. So the idea here would be, this could partly explain the apparent contradiction in some statements made by Cotard patients. That is, if such a patient saying I am dead means it in the biological sense, and it could be a sense in which I am alive, or that expression, and detached from my body in some way, makes sense. There are a couple of those quotes. You remember mentioned something about like I'm like a ghost or something like that. Cotard patients may sometimes be referring to their bodies or body parts, whereas they may otherwise reflect a more first-person perspective on their own mental states. So maybe what seems like a contradiction isn't. I mean, we have to use the language we have. So we use words like I and me often. And, obviously it doesn't always mean we're using them the same way. May have more than one meaning. And of course, in the extreme case, you even have some, or especially in Eastern philosophy, who deny the existence of an I anyway, right? There's no self at all. So to explain that sort of thing, you obviously have to go beyond just the superficial, you might say grammar of these kinds of claims. But they're all very strange, and trying to explain why someone would have this, would say something like that, or seem to really believe it. Now, sometimes people say, well, maybe they don't really believe it, they're just talking that way. But, there's a sense in which even the way they think is rational, right? So oftentimes Cotard patients don't eat for long, long periods of time, right? And so a couple of cases, people are, how come you're not eating anything? And one of them said, well, I'm dead. I don't have to eat anymore. I mean, there's no reason. It was almost like he was upset that they haven't buried him yet. I mean, this is really weird, right? But if you think of it like that, they do seem to really believe on some level, I guess, right? Now, obviously, if you prod them with leading questions, you might be able to get them to admit there's a conscious contradiction in some of the things they say, but that's not always easy to do. So that's one of the ways to reply. There's so many different quotes, very strange things. One thing I will say is sometimes Cotard syndrome is associated with, there is something called dissociative, bodily integrity identity disorder, BIID, where you have patients, which I think presumably also might not be the only, sometimes they have Cotard in addition to other problems. And there have been cases where they literally want their body part removed, like go to a doctor, say, could you amputate my foot? It's not mine. So, it's pretty serious problem, right? Bodily integrity disorder. And so that's what happens in some cases. There are some cases of people have tried to, so frustrated with the doctor that they try to do it themselves. I mean, it's really pretty horrible that they can think like that. So there are ways that they try to, head those things off. People know a lot more about it now, but the Cotard himself lived, last century, and at least this condition has been labeled as such for many, many, many decades. And I'll just leave it there. Thank you.
Thank you so much, Dr. Rocco, for the presentation. So any questions from the audience side?
I'll put my email address in.
70% of the population will experience trauma worldwide in their lifetime. The word trauma derives from the Greek word for wound or hurt. Trauma is often accompanied by a sense of shock, helplessness, or loss of control. Trauma can be an acute or chronic process. The acute trauma response or acute stress reaction is characterized by a short-lived sympathetic fight or flight response. If unresolved or the perceived threats continue, this initial response can progress to a chronic response, often associated with significant impairment and comorbidity. Chronic stress reactions can occur in response to a single traumatic event or following multiple stressors. Chronic trauma usually presents with irregular behavioral and physiological processes outlined in the DSM-5 as the following symptom clusters: hyperarousal states, avoidance behaviors, intrusive trauma-associated memories, and altered cognitions and moods. Although workplace trauma is not currently defined in the DSM-5, it is prevalent in every occupation and is largely unacknowledged. Burnout is conventionally viewed as a byproduct of unmanaged occupational stress. Its symptoms often overlap and coexist with manifestations of traumatic stress. Workplace trauma is caused by the inability to cope with negative events or abuse at work. Because trauma is subjective, each experience is personal. Some examples of workplace trauma include job insecurity, accidents, violence, harassment, toxic work environments, inadequate support systems, and unfair treatment. Leadership should react and intervene to help employees cope and recover from workplace trauma. A leader's core responsibility is to ensure the organization is operating as effectively as possible. Proactively addressing any potential problems or conflicts that could lead to workplace trauma is a preventative measure that will undoubtedly make any business more effective. There is a compelling moral and business case for addressing workplace trauma. The well-being of employees is inseparable from the health of the business. Leaders who prioritize their employees' mental and emotional health are not merely acting out of empathy, they are making a strategic business decision. Trauma can damage brain health by causing structural changes. Trauma can change our brain on many levels, affecting decision-making to immediate subconscious responses. Trauma can cause our brain to remain in a state of hypervigilance, constant state of strong emotional reactivity. Three important parts of the brain are affected: our amygdala, emotional and survival center, the hippocampus, controls our learning and memory, and the medial dorsolateral prefrontal cortexes, which helps regulate our emotions and impulses. All three parts work collaboratively to manage stress. Overcoming trauma can be a very difficult process, but what we have learned is thanks to neuroplasticity, it allows the brain to form new connections to reverse damaging effects. Trauma-informed practices. Why is it important? According to Dr. Bloom, trauma-informed workplaces offer a sanctuary of safety and support, a place where people can bring their whole selves and be valued for who they are. The pandemic presented us with an opportunity to rethink how we work. We have the power to make workplaces engines for mental health and well-being. Doing so will require organizations to rethink how they protect workers from harm, foster a sense of connection, show employees that they matter, make space for their lives outside of work, and support their long-term professional growth. This may not be easy, but according to the U.S. Surgeon General, a healthy workforce is a foundation for thriving organizations and a healthy community. Trust in the workplace is emerging as one of the most popular topics among business leaders and HR professionals across the globe. According to Edelman Trust Barometer, a survey of 33,000 people in 28 countries, 1 in 3 employees doesn't trust their employer. As a leader, it is critical to build trust with those that you manage. Employees that have experienced trauma at work may be hyperreactive and feel a betrayal of trust. How do we start building trust? Well, I believe we build mentally healthy leaders. By introducing trauma-informed practice into your personal leadership approach can be challenging or even overwhelming. But I believe that a truly effective, adaptable leader should become trauma-informed. If we face our afflictions to gain deeper self-awareness, we can become more compassionate and understanding of others. Having that courage to be visible and transparent allows us to embrace our human vulnerability, and there we can create that trusting environment and culture. The goal here is igniting our curiosity to inquire and understand. We want to provide a holistically healthy space and give employees the permission to be human. I am not saying that you have the responsibility to heal employees or to even have all the answers, but we do have the responsibility to care about their well-being. Brave and authentic leaders can step into those painful places with gentleness to see others, to listen to others, and to offer compassion. On the left-hand side, you can see the benefits of having trust within an organization. And on the right side, you can see the mental health costs around the globe. From a psychological and scientific perspective, kindness is beneficial for mental and physical health. The notion of paying it forward has gained popularity through the media and movies and continues to intrigue researchers in many fields, with formal studies emerging on the topic. Although the psychological forces that fuel kindness contagion are not fully understood, research continues to show that kindness is contagious and improves social connections. Universally, kindness is respected and valued. The emotional contagion theory, first characterized by Hatfield, describes how people who observe the emotions and behaviors of another tend to copy those emotions and behaviors. So in other words, it's a phenomenon where the observed behavior of one individual leads to the reflexive production of the same behavior by others. In a computer, our brain has a search function. It is programmed by what we focus on and, more primarily, what we identify with. We notice only what matches our internal belief systems and identified contexts. We can choose to use our reticular activating system to focus on kindness. When we focus on something, that focus instantly creates ideas and thought patterns we wouldn't have had otherwise. Even our physiology will respond to an image in our head as if it were reality. So we can use our subconscious mind to help us focus on the positive. Is kindness simply the act of being nice to someone, or is there more to it? How is it the same or different than altruism? Can a person be kind without wanting something in return, such as a random act of kindness? Is being kind a service to others, to self, or both? These are just some of the many questions posed by philosophers, psychologists, sociologists, and theologians. Before the rise of positive psychology, research centered more on abnormal behavior. The focus was on what was wrong with people and how to fix them. Positive psychology researchers concern themselves with what works in people. One of the aspects that positive psychology promotes is kindness. Kindness can benefit both the giver and the receiver. It can boost happiness, well-being, resilience, creativity, and empathy. Positive psychology interventions that focus on kindness involve simple acts like helping others, expressing gratitude, or counting one's own acts of kindness. According to Morgan 2020, kindness increases our life expectancy by 8 to 10 years. It changes our brain and it changes our gene expression. So according to Miller 2021, being kind makes us strong mentally and physically. It builds strong character, gives self-compassion, creates a gentler mental judgment, and paints a more colorful reality. Kindness is not an easy trait to possess. It is one of the toughest traits because it demands confidence, integrity, courage, and mastery of self. Love and kindness, we may picture a heart, and for good reason. Science shows us that there is a direct link to the heart. We know stress creates stress hormones, cortisol, adrenaline, and norepinephrine. It is how we feel that actually produces the stress hormones. Can love and kindness help us reduce stress? Absolutely. In addition to lowering our stress levels, being kind to others makes us happier and get a warm feeling. Acts of kindness increase serotonin, a neurotransmitter that contributes to our mood and overall well-being. This practice is actually so effective that it's formally incorporated into some types of psychotherapy. We all seek a path to happiness, says Professor of Psychiatry at Cedars-Sinai, and practicing kindness towards others is one that we know works. Kindness is chemical. It generates a response in our brain. It increases oxytocin, often called the love hormone. We experience a connectedness that promotes social bonding, and it can also lower cortisol. Oxytocin stimulates the production of nitric oxide to dilate arteries so that the heart receives more oxygen and lowers blood pressure. It also has antioxidant and anti-inflammatory effects throughout the cardiovascular system. We know that stress can increase aging through free radicals and inflammation. When we experience kindness as a giver or a receiver, our oxytocin levels increase, our blood vessels dilate, and our cardiovascular health improves. It strengthens our immune system, improves our energy, reduces aches and pains, and can lead to a longer lifespan. In the process, you also experience an increase in self-esteem, empathy, and compassion. Kindness has also been linked with releasing dopamine, a chemical messenger in the brain that can give us a feeling of euphoria, lights up those pleasure and reward centers in the brain. This feel-good brain chemical is credited with causing that helper's high, similar to runners experiencing a high from increased endorphins. Both the helper's high and runner's high produce that similar feeling. Other neurotransmitters include serotonin. Many medications that we use to treat depression and anxiety use serotonin because it decreases feelings of depression and anxiety by helping them feel more relaxed. There are 86 billion neurons forming 100 trillion connections to each other, numbers that ironically are far too large for our human brain to fathom. According to the Harvard Medical School, our brains can actually receive hardware updates in addition to software updates. Different pathways form and fall dormant, are created and discarded according to our experiences. So when we learn something new, we create new connections between our neurons. We rewire our brains to adapt to new circumstances, and this happens on a daily basis. But it's also something that we can encourage and stimulate. According to positive psychology, this explains how acts of kindness find their way into the chemistry and structure of our brain. If kindness becomes a habit, we can significantly alter the wiring of our brain. Neuroscience does show kindness activates the brain and improves our brain health. Kindness reduces the harmful stress hormone cortisol. Cortisol, we know, prepares our body for fight or flight, and in stressful situations, this can be helpful. But too much cortisol can impair our memory and interfere with brain function. According to Dr. Hall, kindness can protect our overall health twice as much as aspirin protects against heart disease. It's free, widely available, and has no side effects. According to Dr. Harding, small acts of kindness are an essential and often overlooked component of health. The simple human act of kindness has numerous health benefits. It is good for the body and also good for the mind. According to Short 2024, embracing trauma-informed leadership is not only a moral imperative, but also a strategic investment in the well-being and success of both individuals and the organization as a whole. Trauma-informed leadership is a framework for promoting well-being, fostering resilience, and creating supportive organizational cultures. It goes beyond that traditional management approach by acknowledging the effects of trauma on individuals and organizations. Benefits include reduced employee exhaustion, absenteeism, and burnout, with increased psychological engagement, well-being, positive emotions, and commitment from workers. Organizations that prioritize trauma-informed leadership demonstrate a commitment to empathy, equity, and social responsibility. It aligns with the principles of ethical leadership, which fosters trust, loyalty, and long-term organizational sustainability. Some of the many benefits of kindness and compassion in leadership include improved employee engagement and satisfaction, better employee well-being and mental health, better financial performance, increased retention and loyalty, increased creativity and innovation, more effective conflict resolution, reduced workplace stress, stronger employer brand, increased productivity, and culture of collaboration. Compassionate leaders recognize that their colleagues are more than just the challenges that they may be facing. They try to see and acknowledge the whole person and seek to grow them. Compassionate leaders strengthen trust, creates greater cooperation and grace for all. Remember, compassion is the heart of relationship building, and leadership is a social process. So my hope, by utilizing trauma-informed leadership and kindness and compassion, we are able to build resilient employees by promoting well-being. Happier employees are better able to cope with stress and setbacks. And research shows that resilient employees perform better. I want to thank you for taking this journey with me as we explored trauma. We identified kindness from a psychological and scientific perspective and discussed ways to build resilient employees. Most people may think that gratitude and small acts of kindness are separate actions or feelings, but they go hand in hand, especially when it comes to building resilience. Resilience, by definition, implies there's some adversity or obstacles to overcome. So while it may seem strange to form gratitude around the idea that we can be grateful for obstacles we faced in our lives, but those obstacles are often what pushes us towards positive outcomes, and positive outcomes are good for our mental health and well-being. So I'm going to leave you with a notion that even in our hardest times, there's something that we can be grateful for, and there's always room to practice kindness. Thank you for your time and attention. I leave with an attitude of gratitude.
Okay. Uh, I hope the audience have benefited by the video presentation by Clarin Jacobs. And if anyone is having any question,
have no conflict of interest. So before we start, I'm going to give you like a little advance or an idea of where we are. We are a little country that's located in Central America. As you can see in the picture, our country is really, really small. So if we make zoom, we're located between Nicaragua and Panama, and we have a population approximately about 5 million people, in which, because of the nature of our social security system, we provide health services from Managua in Nicaragua up to city of Panama. Our social security system is based in the principles of universality and also with the principles of solidarity. So that's why our hospital has to provide services to all this population. Also notice that the the National Children's Hospital is the only hospital in our country and in the region that has like the highest level in health services. So, to advance with our topic, we have a prevalence of 3 to 9 patients per 1,000 people of prevalence in epilepsy. Also, the incidence is from 30 to 50 to 1,000, 100,000 people in incidence of epileptic patients, and the drug resistance in this population is from 10% to 30%. Well, as you can see, this is not a little percentage, is really, really high. And by definition, we can say that the refractory epilepsy is the patient in which we have already used two type of different medication. It could be in monotherapy or it can be in combination of this, and that we cannot control the seizures or adequately reduce the amount of seizures. Because of that, we have the unit in our hospital that is dedicated only to study this amount of patients. This unit has gone through two periods of time of evolutions, to say it in a different way, in which the first one goes from the 90s up to 2000, and the second period of time goes from 2000 up to the current day. In these two periods of time, we have studied 986 patients, and of these 196 patients, only 145 patients have underwent any kind of surgery. This includes hemispherectomy, temporal lobectomy, hydrocephalus, stimulation of the vagal nerve. But today we are going to focus only in the hemispherectomy and in the temporal lobectomy patients, because these patients are the ones that has the biggest amount of seizures and the most difficult seizures that can be controlled. Also, these patients have reflect the biggest transition of the biggest amount of money that we can save in these patients, just saying in the part of the medication. So that's why our main goal in this study was to analyze the relationship between the investment in epileptic drugs that we used in these patients before they underwent surgery versus the amount of money that we spent in anti-epileptic drugs after the surgery, essentially in hemispherectomy and in temporal lobectomy. Like I said, this study was made between 2000 and 2019. These patients were the ones that we selected. And in the specific goals that we had when we made these investigations was basically determine how much do we spend in medications before the surgery, how much we spend after the surgery, and compare it. Do we have savings in these patients doing the surgery, or do we do we keep the same amount of antiepileptics, or do they get worse? That was basically the specific goals. Also, how much time that it takes to take the decision for the team that includes neurologists and neurosurgeons to say that these patients have to go through surgery, or do they are not candidates for any kind of procedure. Basically, we have protocols that makes our study easier in a kind of way. This include the hemograms, the electrolytes, the glycemia, of course, the amount of levels in anticonvulsivant levels in blood, because if a patient is with a low level of anticonvulsivants, of course, they will not be candidate for any kind of alternate intervention, like any surgery. In the cabinet, we basically have the electroencephalogram, the evolved potentials, and the most important are the CT and the MRI, just to be sure that there are no kind of lesions or tumors or anything that could be provoking the seizures. Now, talking about the costs, every patient that goes through an emergency service and needs consultation, they have like a base cost. This cost is around $113 per consultation. In the general medicine, just for example, the first approach that the patient receive when they apply to the ER, the specialist consultation costs around $132. And this is important because we are a public hospital. The costs even of the hospitalization and of the medicines, they are a lot lower than if we apply to a private hospital. For example, the hospitalization day in our hospital, this is a general public one, is around 1,487, and the ICU day is around $3,000. Also, the surgical time is the surgical price is calculated by time, not by procedure. So, if, for example, an hemispherectomy that could last 3 to 4 hours, it will approximately cost $4,000. Also, the CT and the magnetic resonance, the costs are lower for the public services, so they are around 270 to 290. So as you can see in this image, uh, these are all the drugs that we use in these patients, and just notice that we use generic drugs. We don't use brands. Why is that? Because we only, in the public's health insurance, we only buy generic drugs. This lower costs a lot, and it is easier like to calculate the amount of money that we can that we save. We'll see it later. So as you can see in this image, this is about just the medicine distribution, and I divide it in the amount of drugs that we use before surgery and the amount of drugs that we use after the surgery. For example, the carbamazepine, it goes from 10 patients, it's just to one, in tablets from 16 to 6. And as you can see, it reduces a lot of patients that use this amount of drugs. You can see this in a little bit more clearly, that after the surgery, the amounts of drugs that were used get lower. Just like in a little, like two cases, for example, in the levetiracetam, kept the same, and in the phenylethylamine, it increased. These examples could be related in patients that used more drugs, and after the surgery they prefer to use these the neurologists prefer to use these kinds of drugs to control the seizures. So in this image we can see the patient distribution. The drugs, well, this will be the patients and these will be the drugs that they use before and after the surgery. So for example, we can see that this first patient used before the surgery up to 9 kinds of antiepileptic drugs, and it went to 3 after surgery to control the seizures, and so on. We can see that these patients use a lot of drugs, and after that they reduce the amount. Of course, there were also patients that kept using the same amount, but the amount of seizures were lower. So in the end, it reflects the amount of savings. Okay, in this one, we can see the amount of time in month that went that we spent studying patients or trying to control it before we decided to proceed with the surgery. As you can see, up to 131 months being the highest and the lowest being 11.3 months in the selected patients. So what we concluded, the population of patients that underwent hemispherectomy and temporal lobectomy were 69. Because we have a lot of trouble gathering the information, and the information sometimes is badly kept. The only patients that have the complete information that we needed were 31. So that's the sample we used. In Costa Rica, the life expectancy of the epileptic patient in month is 828 months. So we calculated the average monthly cost of these patients that were 50, let's say $54, and the average monthly cost of these patients re- reduced up to $33.62. So the savings were $34. This seems little, but if we infer or extrapolate these savings in the 69 patients, that would be the population, it will be $1,400 per month just in these 69 patients. And if we infer these savings up to the life expectancy, it will be $440,000. And also trying to make the exercise with the population that are $69, it will be almost $1 million of savings in just these patients. Also, it's important to remark that the amount of money that we spend in a patient in antiepileptic drugs, they are just about the 10 to 20% of the total amount that we need to use or to pay in these patients. Like we see before, they also need ER, they need consultation specialists, they need labs, they need X-ray, CT, MRI. So if we can say that this $1 million are just the 10% that we use in these patients, so if we make the exercise with the other items, we could say that the total amount of savings could be around to 10 millions up to $20 million just in these patients. Okay, this we were talking about just the amount of money, but we can our clinical results in the hemispherectomy patients are really good. According to the Angel scale, 85% of our operated kids are almost free of seizures, or their lifestyle have increased considerably, even also for their parents. And this is the bibliography that we use for making this investigation. This this was one of our patients that was operated 6 months in the post-operatory 6 months, just like a little data that all of our patients can walk. It's like a really good clinical outcome in the follow-up. So I don't know if there is any question.
Thank you, Dr. John. Is there any question from the audience side? Okay, so I'd like to
research on substances with individuals who have intellectual disability. They are not often included in this line of research, and research has proposed that having a diagnosed intellectual disability may serve as a protective factor against misuse. However, individuals who have intellectual disability have been shown to have a higher risk for substance misuse and mental health diagnosis than the general population. Individuals with intellectual and developmental disabilities are increasing their participation in mainstream activities, which is believed to increase their exposure to opportunities for social experimentation and possibly substance, certainly use and misuse. Despite the recognition of these concerns within the disability literature, a gap remains regarding first-person perceptions of substance misuse among students and young adults in particular. Consequently, there is a growing demand from disability advocates to both understand and address substance use and misuse in college-age students with disabilities. So let me explain to you, before we get into more of some of the issues I would like to talk about, exactly what population I'm talking about. The program that we have here at the University of Memphis, in Memphis, Tennessee, is one called Inclusive Higher Education. An Inclusive Higher Education program, IHE, provides individualized programs of study in the areas of academic, social, vocational, and independence for students aged 18 to 29 with a documented intellectual or developmental disability. And the term we use, and I believe it's used in many places, is neurodivergent. So these are young adults that are neurodivergent. The most obvious one is the documentation of an intellectual or developmental disability, but we are getting more and more young adults in this category who are coming with the diagnosis of autism and traumatic brain injury. In any case, it's still okay because those are all neurodivergent issues, and they fit into these inclusive higher education programs because they wouldn't otherwise be qualified to pass the entrance tests to get into the mainstream university-based program. So that is the criteria. They have to have a documented intellectual, developmental, or other neurodivergent disability. And they have to be otherwise not able to enter the University of Memphis or any university where a program like this exists. And for us, we say between the ages of 18 and 29, because if they get much older than 29, they really are not consistent with the other university students that are part of their therapeutic intervention here at the university. The concept behind inclusive higher education is that by bringing these young neurodivergent adults into the university population, they are going to learn skills that are going to get them employed. If you see at the very bottom of the screen, there's a picture of some of our Tiger Life students. Our program is called Tiger Life. They have to have completed high school under an IEP here in the United States. That's an individualized educational plan. Or they can have some other diagnosis if they haven't had an IEP in high school, but they come in with medical documentation of the neurodivergence, they're also acceptable. And they have to have a desire to be gainfully employed. So our program, this one here at the University of Memphis, unlike some of the IHE programs, focuses on employment, the ability to maintain competitive, integrative employment. So full-time work in an integrated environment along with people who are not disabled. That's really critical because I'll share with you a little bit the data on that here in the United States isn't that great, and I can't imagine it's better at other places in the world. They also have to be able to function independently without one-on-one assistance. So it's not every person who's neurodivergent and can't get into college that comes to inclusive higher education. They have to be independent enough to function in a competitive environment. So that would be the exclusionary feature of the program. Tiger Life, our program, is a continuing education program that provides students with employment and independent living skills. Students take college courses, usually not for credit. They usually do them for audits so that there's not that actual pressure on them to get a particular grade, but rather to accomplish the goals of the class. They have internships and jobs, both on campus and in the community. And most importantly, they build relationships with their peers without disabilities. This is what we feel, and what I think we have demonstrated is the critical difference in getting employment. These relationships with peers translate into the work experience. So many of these young neurodivergent adults could get a job, but they wouldn't be able to keep the job because their behavior or their inability to socialize with other employees, or their inability to maintain a relationship with their supervisor is impaired because of their disability and because they haven't really had that experience in high school in the way that we promote that experience here on the university campus. So that in itself, I personally believe, having observed this for well over a decade now, is the most critical part of it. It is the ability to integrate the social experiences of these young adults with typical non-neurodivergent students on campus, and the relationships that they build. So if I'm hanging out with people and I'm socializing and I'm going to the fraternity party and I am sitting down at lunch with non-neurodivergent peers, and I'm sitting in classes with them, and they're all going to go to work, I'm going to go to work too. I'm not going to let my disability impair me from being just like everybody else that I have now learned to interact with. And they may have been kept from that kind of interaction in high school. I don't want to blame the secondary schools, but it's a lot easier to just keep people that are different in different places and not in the mainstream of activities, even though here in the United States, we've been working at this for over 50, 60 years. It doesn't always happen. Here on our campus, it happens that way. And it happens in the United States on more than 300, I believe there are 317 university-based, not just post-secondary, but university-based programs. You can find the information about this on a website called Think College. Think College. They will give you all the information of where this is in the United States, how many states have programs, what universities have programs, but over 317 institutions of higher learning have welcomed these young adults to the campus and have a very good success rate, both in the socialization piece of it and in the employment piece of it. Tiger Life is one of the additional ones that are federally recognized as a comprehensive transition program. So what that means is, based on the Higher Education Act of 2008 here in the United States, if you are accepted as a CTP, the students can get the same funding streams that non-divergent students get. They're eligible for Pell Grants, they're eligible for work study, they can be brought into the university community, usually under continuing education, but that depends on which of the 317 places you're at. Sometimes they're brought into the regular mainstream program also. This is just how our university has decided to handle it. Tiger Life programming, the IHE, the Inclusive Higher Education, is administered by the University of Memphis Institute on Disability, and I'm the director of the institute. And our purpose is to assist people with all disabilities in finding meaningful, comprehensive, integrated employment. That means competitive, should be comprehensive. We have to fix the slide. It means in a competitive environment, not in a sheltered environment. It means with and including people who are not disabled. It means full-time work. It's a real job. Partnering with vocational rehabilitation agencies, and here the place we're located geographically in the United States is right at the corner where Tennessee, Mississippi, and Arkansas, 3 of our states, come together. So we have not only Tennessee, but a regional influence on bringing these people to campus. The primary goal is to provide career exploration and internships that will help the student experience a variety of potential work environments. And then we also actually place them in jobs. So let me tell you, we have had in the state of Tennessee, here in the United States, in the last decade, there have been 683 young adults that have gone through these programs in the 9 universities and that provide the 9 institutions of higher education that provide this service. 318 of those have come from our one program at the University of Memphis. So we are the largest and the most productive program in Tennessee. And that's because we are committed to this activity. We're not just doing this as, oh, it's a nice thing to add to programming. We're doing it because we believe these neurodivergent young adults deserve a competitive job. The data in the United States is not great in this area. In Tennessee, between 16 and 17% of people with cognitive disabilities, neurodivergent persons, ever get competitive, integrative employment. In the United States as a whole, a little bit over 20% of the people who have cognitive disabilities ever get competitive, integrative employment, full-time employment. That would mean giving up their Social Security disability check and taking a real job. The graduates of our program, the over 300 graduates of our program, 70% have gotten real jobs. Not 16%, not 20%, but 70% have gotten competitive jobs. So we know we are making a significant difference. And inclusive higher education across the board, even the ones that don't emphasize employment as much as we do, have made a difference. So nationally, they are at about 50 to 60% competitive employment. So these programs really do make a difference. Now, that's the good news. So let's look at what this particular study we're about to do will have, and I'm looking forward to some suggestions from you all, perhaps in the chat, about how to go with this. So this will be a qualitative study. It will be to explore the lived experience of post-secondary students who have intellectual and developmental disabilities, and some also have physical disabilities, by exploring the experiences and perceptions of substance abuse within the lives of these post-secondary students. And the study will identify ways in which we can perceive and change any misuse and abuse. The study will use our students currently in the Tiger Life program at the University of Memphis Institute on Disability. It'll happen in the spring of 2025 and be evaluated in the fall of 2025. And traditional qualitative methods will apply in a Delphi study. Approximately 30 young adults with intellectual and developmental disabilities will participate in the study. We have that is large for a typical IHE program. And the goal will be to find the best intervention. So where are we? Why are we in this situation? We have looked at the literature in both the USA and international literature in this area. And there is a definite problem, not necessarily with our 30 students, but a problem in this population of young adults with intellectual and developmental disabilities. And the problem is maybe their own use or abuse. It may be the social interaction that comes from interacting with other young adults that have substance misuse issues. It could be because the family that they come from has these problems and has caused disruption in their life. But the most important thing is that it affects their ability to work, because as I said before, the reason why they're here is to get competitive integrative employment. And we know that problems with substances take away from that ability to compete in the employment area and detract from employment once you get it. So we'll use the capital model to explore barriers to the facilitation of recovery. And the recovery model appears to be in line with a model that we use here at the Institute on Disability that was created by Geist and Calzaretta in 1980s. But the recovery model approaches substance abuse as a recovery from 5 domains: human, social, cultural, financial, and community recovery capital. And it explores the barriers to recovery. This study is was based on a very small comorbidity panel, and that's why we want to approach it as a qualitative study. But it uses a systematic framework to assess aspects of recovery. And it points out, it pointed out in this article, the fact that way more research needs to be done. Let me show you the model that we use here at the Institute on Disability for all of our persons with disabilities, whether they're neurodivergent or have other kinds of disabilities, such as psychiatric disabilities or physical disabilities. And that is the systems approach to life transitions. And as I said, this is a model developed in the 1980s and researched. Instrument has been developed to measure pre and post intervention using this model. And of course, the person with the disability, the person that's neurodivergent or different, is the center of the model. Everything focuses on that person. As opposed to saying person-centered, we like to say it's a person-driven model, because we're not doing something to the person is driving the model. The errors that are assessed are the client issues themselves, both their health and other pieces connected to how they interact, what their capacities are, what their levels of independence are, etc. The social inclusion piece is education and family. We want to look at what's going on in the family system. We want to what has gone on in their educational system in the past, and what's going to go on in the future, and what has happened while they're here. And some of our young adults go on for additional training. They go on to get formal degrees. Once they have been with us, they've learned the capacity to focus and attend much better, so they can go on and get traditional degrees. We have a young fellow who's leaving us in December. He's finishing our program, and he's going on to a community college, and he's majoring in theater. He's taken theater classes here at the university under our program, and now he's ready to go out and be independent, and he will work at some point, but he wants to go on and get at least an associate's degree in theater, and that is fantastic. Ultimately, he will go to work. So looking at both the educational and the family piece of this is really critical. We do behavioral support. That I may have clearly mentioned that. If not, we do have a behaviorist that we contract with that does independence assessments, travel assessments, and intervenes whenever we need behavioral intervention on the staff. She's a consultant. And in that case, we look at the social issues. Again, can the person not only get a job, but hold that job? And then we also look at employers. So we have a cadre of employers that have hired our young adults in the past and will continue to hire them in the future, and know that when we bring them to them for job placement, that they are going to be productive and they're going to be able to maintain that job. And then we're always looking to develop new employers and share this whole experience with new employers who will ultimately hire our young adults. And the last piece, of course, is funding, which is critical. And we are very lucky that about 50% of the tuition here at the university is paid for by the vocational rehabilitation systems in Tennessee, Arkansas, and Mississippi. So we get about half of the cost of the program is covered by vocational rehabilitation. And then there are other grants available from the states. And then sometimes people have to pay something if their family is very, very well off. But if they aren't, most of it's going to be covered by the funding and the grants to come to the program. And then working on job placement is really, really critical. Working on job placement is the ultimate in this. It's talking to employers, as we said, but actually developing the things that are needed for them to get ready to be able to go out to competitive employment. So these are the things we're hoping to come up with. First of all, is there a problem to solve? Is the influence of substances and problems connected to substance use and misuse affecting the ability for the whole inclusive higher education program to move forward, or for any individual in the program to move forward? Is this actually solvable? Or is this a problem that is so beyond our ability to tackle as part of the program that it's not even something that we can handle? And we'll find that out by this qualitative study. If there's an intervention, what is the best intervention? When I went to a symposium like this in 2019, the last international symposium I got to go to before the pandemic, we were talking about all of this back then. It's gotten a little bit behind, not the program, not the IHE, but this particular aspect of it, because of the pandemic and loss of connections to the international community. But what we found in talking to people at a similar face-to-face days like we're spending today was that there were no interventions in the substance abuse area for people with intellectual and developmental disabilities, because the interventions that are usually used are bibliotherapy, reading pamphlets, reading books. Another popular one is group interaction, and some of our young adults can't read well. They may be reading at the 3rd or 4th grade level, and the books that are used in substance abuse treatment are at a higher level, and they may not be able to interact in group counseling. They may be better suited to individual counseling. Group therapy is the usual intervention for substance abuse issues. And then there's the issue of cost. Is there insurance to cover this? Is the cost affordable? What I did learn at that meeting in 2019 is that cost, it may be a bogus issue, that if these young adults are still insured on their parents' insurance, that they may actually be able to be involved in programs and that the programs can be paid for. So that in 2019 wasn't an issue. It'll be interesting to see what it is in 2025. But the main issue is that there are no formal interventions that we could find either in the USA literature or in the international literature that targeted this particular population. And that is why I bring this to you, and hopefully somebody will put some comments in the chat that will help me to move forward. Maybe there's an intervention we could already start with in addition to what we find in our qualitative study. So these are some references for you. I believe all of the material will be available after the meeting for people. If not, if it hasn't been sent in, I believe I've sent this in to the sponsors of the meeting to be able to share with you. But if not, I'm certainly happy to send it to anybody as an individual. And I'm certainly willing to share what we have found. As you can see, there is the major pieces in this are in the international literature, not in the US literature. So that's a problem. So if there are any questions or comments, and then this is how to reach me if you want to talk to me about this or do something else. I bet I'm out of time.
So thank you so much, Dr. Kristen, for the presentation. So any question from the audience side? And Dr. Kristen has already left her email address in the PPT. So if anyone is requiring any questions or
introducing myself, I'm Dr. Leighton J. Reynolds. I practice in the greater Los Angeles area. My practice is treatment and tools for trauma. I see severe PTSD, I see trauma to the brain, and I see psychosis in my patients. And as a result of doing this kind of work, specifically over the last 8 years, I have found the Western medicine system, which I'll describe how I see it in a moment, to be inadequate to treat these kinds of patients. And specifically, what I want to address is I have objections to Western medicine, which can be very useful for emergency situations, but in these kind of situations, I don't think the scope is wide enough. And so the title of my article, which I am publishing in the Journal of Neuropsychiatry Reports, coming out on November 28th, it's entitled The Case for Symptomatology, Impairments, and Healing Ecology. So again, how I got here, because I always want to know, how do people get to a particular place? Working with these kind of patients over the last 8 years, I have not found it helpful to be reductionist or fragmented or drug-based in treatment. So I'm presenting an alternative, and in presenting an alternative, I'm also concerned about the social context in which you challenge the current paradigm, and that's what I'm doing. So in my article, I began by telling a story, which I think is still true of me. Probably a good 30 years ago, working on a psychiatric unit, there was a particular incident, I think, that says a lot about who I am and what I'm trying to do and what I'm challenging. And I'll get around to the specifics of the challenge in a few moments. But on this particular night, as I was walking down the hallway of a psychiatric unit in a general hospital, I heard the charge nurse calling my name, and it seemed very urgent, and she seemed very distressed. And as I walked down the hall, I realized it was my patient, and the charge nurse was standing in the doorway to prevent my patient from leaving the unit, which was an open unit. And she was yelling for me to come immediately to do something about this. And in that moment, that was my patient, I thought, if I come running down the hall, I'm just going to scare my patient. He's going to bolt through the door and hurt the charge nurse. So I walked down the hall quietly, and I spoke to my patient and made the suggestion that we sit down and find out what was bothering him, which we did. He apologized to the unit, and I thought, okay, problem solved. Let's go back to work. Everything's okay. The very next day, I was called on the carpet by the director of the unit for not following protocol. I was not listening to what the charge nurse wanted me to do. I was thinking on my own. And I do fault myself and the charge nurse, because we could have talked about this afterwards and I could have shared my thoughts with her, but I didn't, sadly. And she didn't come and talk to me. She went through the director. I got called on the carpet. I suffered some consequences for that, and life went on. But here I find myself challenging Western medicine because, in my opinion, and I am a clinical researcher, the research that I get is from listening to my patients. And the project that I am researching is entitled Listening to the Brain, because I believe that's possible, Recovering the Brain. So in the course of that, in looking at patients, I came up with the idea, the perspective, that what really matters with our patients is their symptomatology, which I'll define, their impairments over diagnosis, and structuring a healing ecology for patients. Oh, let me first of all describe symptomatology. My definition of symptomatology is wider than if I look it up in Webster's dictionary or Oxford dictionary. My definition is that I'm referring to a collection of symptoms a person is struggling with because of major disruptions to their homeostatic, allostatic balance and processes in the body. And where I'm going with all this and how I kind of arrived at this definition is that when you injure the brain, in my opinion, it's a pervasive problem because the brain is a pervasive organ. It all works together, and we can't specifically be just narrowed down to one fragmented or reductionist part of the brain if we expect people to be better. So the Oxford definition is the study of signs and symptoms of a disease that occurs that is what describes symptomatology. Webster's dictionary says it's the complex of a disease, but I see it in a much wider context. And it's again because if I look at the symptoms of trauma to the brain, the list is like 20, 25 symptoms. Well, where is this coming from? This is coming from the fact that all injuries, illness, and disease disrupt homeostatic balance and the allostatic process that holds that together and creates what is now understood as allostatic load. That is, the amount of stress on the body exceeds the body's ability to cope. And not only from injuries and illness and disease that occur to the brain, but constant stress for any of us. And I think we live in a world that's incredibly stressful all the time. What this does is it puts a load on our system of homeostasis and allostasis that makes homeostasis work, keeps us in balance. And over time, we wear down that system, and that system creates an allostatic load, and actually the system begins to turn against the body and really wear it down. And again, where I'm going with this is that the present notion of medicine that looks reductionist, what's the problem with the kidneys? What's the problem with your sore throat? What's the problem with your broken arm? Is not enough to help patients heal, especially when it comes to damage to the brain. And again, injury to the brain, illness, disease, all of this encompasses almost everything. And again, we have to have, in my experience over the last 8 years, a very different kind of approach. So in my mind, symptomatology looks at homeostatic balance, the process of allostasis, which keeps that balance in good health, and the amount of allostatic load that the person is struggling with. And I think if we want our patients to be better, we have to do something more than give them medication or a treatment. We have to look at the whole system of symptomatology that occurs because of injury, illness, and disease. So that's symptom. The second part of my perspective, again, I'm challenging Western medicine here, is impairments. At the World Brain Congress in Los Angeles in 2023, there was a lot of talk about understanding the patient's impairments over their diagnosis. Diagnosis matters. It gives us a perspective about where to go looking for answers. But it doesn't necessarily address how this person is impaired in their day-to-day functioning. And what I see with trauma to the brain, injury, illness, and disease, people lose functionality. And that's critically important in terms of how we treat people. So the suggestion at the conference in LA in 2023 was that we think about impairments over diagnosis. And I think that that makes a great deal of sense. The third part of symptomatology impairments is a healing ecology. And what do I mean by that? I noticed with my brain injured patients that depending on how long it took them to get into my office, a recent car accident, a football injury from 10 years ago, they fell off a ladder at age 10. It depends on how much distress they're under. And what they need, I think, my conclusion is they need a schedule every day that works on healing. It's not just taking a medication. It's not seeing the doctor every month. It's not taking a procedure. It's a full-on schedule of how you heal the brain. And an important piece of this, in my experience, is the importance of the doctor-patient relationship. In many of my cases, I don't just see my patients once a week. I see them sometimes 5 days a week because they need an organizing agent in their life. They cannot process very well because their brains are injured. So in terms of a healing ecology, in my experience, there's two pieces of it. One, you have a whiteboard in your house and you have a schedule every day that involves healing. And I'll show you my protocol in a minute. And the second thing is you need a person on a regular basis who's going to help you with organizing yourself because you can't process things very well. And let me take a step back. So that's the explanation of symptomatology, impairments, and the healing ecology, which has two parts. Let me also say that part of my research work over the last 8 years is creating a model, the complex architecture of trauma to the brain. And what I've come to understand is that trauma to the brain, be it a blow to the head, be it seizures, be it a stroke, be it illness, be it infection, be it a major mental illness, be it long-term PTSD, all create a neurodegenerative process in the brain. And one of the findings I keep coming across is how many people out there have injured their brains and it's not being recognized by medicine as the root of the problem. I see it so often. So-and-so fell off a swing set at age 8, suffered a concussion. They went to the emergency room. Everybody said, he looks fine. Let him go home and rest. Okay, everything's fine. Everything's not fine because concussions, and I think all trauma to the brain, is neurodegenerative. It begins that process in the brain. So by the time this 8, 9, 10-year-old boy is in junior high school, he's a behavioral problem, and people send him to the psychologist to change his behavior. But what I have found with my patients, because by the time they're 20 years old, they're having huge struggles sitting in a college classroom, is that this is part of a neurodegenerative process and they're only 20 years old and they have problems. I find this stunning, how many people that I come across who have injured their brain in some kind of way, it's not being recognized by medicine. They have symptoms they don't understand, and they have a terrible time organizing their life. And what I find by listening to the brain, by sitting with my patients, and I forgot to mention at the beginning that I'm trained as a neuropsychoanalyst. I have my doctorate in psychoanalysis and neuroscience, so I am able to work with mind and brain, which I find essential in this kind of work because every injury or trauma to the brain is also a person. And you have to work with the person just as much as you have to work with the injury, the disease, or the illness. So as a result of seeing what's out there in a whole different way, I came up with my model of the complex architecture of a traumatic brain injury. And that involves shock trauma to the brain, The brain goes into a survival shock when it's injured in any kind of way. And that's usually not recognized. And in some cases, that shock trauma can occur a couple hours after a car accident, after a football game. It can occur 2 weeks later, but the brain goes into a survival mode, and it's very difficult for people to negotiate the world if their brain is totally in survival mode. After architecture 1, architecture 2, the neurons themselves from injury, illness, or disease begin to break apart, they get twisted, they get sheared, they don't work. So there's a failure of electrical and chemical communication in the brain. That's how the brain communicates. And so there are disruptions in brain functioning, and people begin to lose functionality. Number 3, the third architecture, again, I use the word architectures because the brain is constructing some way to respond to being damaged, not successfully so. So by architecture 3, what I've noticed is homeostasis, allostasis is being replaced by allostatic load, and that system is not working anymore. And people have huge numbers of systems because their balance is not working properly and needs to be addressed. And finally, architecture 4, and I think this process, this model applies to many different illnesses and diseases. Architecture 4 is the perfect storm in the brain when you have a TBI or trauma to the brain that slows it down. People's brains are functioning like a slow computer. And you have an opposite process, PTSD, speeds up the brain with stress hormones. So as I began to work with that model, I came to the conclusion that, again, a reductionist, fragmented, drug treatment-based medicine is not enough for these people. Certainly it can be helpful to some people. But I think these kind of patients, and I'm seeing more of them everywhere, unrecognized. Yes, and I'm pausing to say I published a book a year ago, The Complex Architecture and Healing of Traumatic Brain Injuries, with Cambridge Scholars Publishing. That is a number of cases. I think there's 10 cases in there of successfully helping people negotiate trauma to the brain. And again, it's led me to think differently about the practice of medicine. And I'll end, and there's so much to this. And again, I'm challenging the system. 1 second here. I developed a protocol, and my protocol is as follows for working with these kind of patients. But again, I believe it's applicable to many, many medical cases. And I think the key for me is understanding a patient not as a set of lab values or a person for whom we're going to do a procedure to, but all our patients are subjective experiences. And that's really what we need to focus on. And I learned that lesson in my psychoanalytic training, because psychoanalysis is interested in, 1, the unconscious, how that drives everybody. Number 2, it's interested in people's resistances being treated. And number 3, it's interested in psychic structure. That's a very different approach than handing out antipsychotic meds or antidepressive meds, or even cognitive behaviorism, which says, hey, look, we're going to change your thinking, change your behavior. It's a very different approach. So in working with my patients, to leave you with some thoughts, and again, I'm happy to get feedback and questions from people from all over the world. That's my hope. Number 1, you have to take a good history, which takes time. Number 2, I'm very big on nutrients for the brain and for the body as opposed to drugs, although I know that drugs can be helpful, I think, on a short-term basis. Number 3, I think you have to get people immersed in a healing ecology where every single day they're working at healing injury, illness, or disease. Number 4, I think there has to be some stimulation to the brain. And I found music to be a wonderful help. And there's a new book that Daniel Levitin just published. He published This Is Your Brain on Music probably 2 decades ago, and he's just following up his research on how important music is to the health of the brain. Number 5, the creation of flow experiences for people. Dr. Schick's original book in 1990, Flow, talks about order and organization in consciousness when people get captured by an experience. It could be art, it could be music, it could be rock climbing, playing a tennis game, watching a movie with somebody you love, whatever. When your brain is captured by the experience, also sometimes called experiential fusion, when you're fused with the experience, what I notice is that it reduces demands on the brain and allows the brain to begin to heal. But I think that's true for everybody, to be engaged in these kinds of experiences. And again, I'm coming from the standpoint of the clinical researcher who's looking for answers in the day-to-day work that I do with patients. I also recommend in my protocol that people get chiropractic treatment because it aids to the health of the nervous system. The nervous system stimulates everything in the body. And I notice on my own chiropractic adjustments, I always have more energy when my spine is clear. Also, from the 2023 World Brain Congress in LA, we concluded that all head injuries are also neck injuries, and all neck injuries are also head injuries. And I have found that to be absolutely true. And finally, I believe in the value of neuropsychoanalytic sessions up from 1 to 5 times a day, because talking, having a relationship, I think is one of the best ways to stimulate new growth in the brain. And there's the argument as to whether you're actually creating new neurons in the brain through neuroplasticity, or whether you are using what's there in the brain already that hasn't been used before. So if you have any questions, or you want to reach me, or you want to look at my article, which again is in the Journal of Neuropsychiatry, it's volume 2, issue 4, 2024, 1128. This gives you much of the case information that is in the article that I didn't present with people here. But I'm very interested in feedback from people, because again, I'm challenging the current system. And sometimes that's hard on me because I don't think like everybody else does. But in my opinion, based on my observations with these kinds of patients, which I think applies to all patients, this is a better approach to healing. Does anybody have any questions at this point? And again, I appreciate the organizers of the conference for giving me this opportunity and for putting this on once a year. I'm sorry I couldn't be in Bangkok. Questions?
Il mio articolo è sul processo riflessivo dell'oggetto 3D nella 3D therapy, mentalizzazione e flessibilità mentale. Allora, molti soggetti giungono in terapia e non sono in grado di riconoscere le emozioni, non riescono a vivere in maniera tranquilla, e queste emozioni sono delle emozioni negative che bloccano la mente e impediscono di pensare e anche di organizzare comportamenti efficaci ed adattivi. Il setting terapeutico, caratterizzato da una relazione paziente-terapeuta, impronta un'accettazione incondizionata, una comprensione empatica, un comportamento congruente, a tal punto a finalizzare tutta l'interazione ad un'attivazione di un processo correttivo-riparativo sul principio dell'entrare in rapporto con l'oggetto. Il soggetto consente che certe modificazioni abbiano luogo nel suo sé. Questo è quello che Winnicott nel 1999 evidenzia.
Okay, many individuals in therapy are unable to recognize the emotions they are experiencing and fail to trace the underlying cause. Negative emotions block their mind, hindering thought processes, and persist as dysfunctional images or belief. This results in difficulties in organizing effective and adaptive thoughts and behaviors. The therapeutic setting, defined by a relationship between patient and therapist, based on unconditional acceptance, empathic understanding, and congruent behavior, creates an evocative interaction. This interaction externalizes emotional experiences and dysfunctional beliefs, facilitating the activation of corrective reparative processes. As Winnicott said in 1999, the principle is in engaging with the object, the subject allows certain changes to occur within their self.
Nella metodologia della 3D therapy, il terapeuta durante la seduta di psicoterapia quindi evoca nel soggetto i vissuti e delle emozioni disfunzionali e pensieri negativi nel qui ed ora, attiva il processo di esternalizzazione verbale e li traspone in forma grafica, che sarebbe la fase A. In più viene trasformata la fase grafica in oggetto 3D, fase BX, che è caratterizzato dallo stesso soggetto, che viene presentata allo stesso soggetto sulla lavagna a luci alternate, fase CX. In questo caso l'oggetto 3D rappresenta la materializzazione delle emozioni disfunzionali, quindi paura, rabbia, colpa, vergogna e tutte le convinzioni negative. Lo stesso oggetto, riproposto alla paziente, propone il vissuto esperienziale evocato nel setting in termini concreti e visibili.
The therapist's role during the psychotherapy sessions is to evoke the patient's dysfunctional emotions, negative thoughts, or repetitive themes in the here and now. The activation of verbal externalization and transposition of these into graphic form in the phase A, and the transformation of the graphic representation into a 3D object, which is the phase BX, which is presented to the patient using an alternating light board in the phase CX. The 3D object represents the materialization of dysfunctional emotions, for example, fear, anger, guilt, shame, and or negative beliefs. And it reproduces the experiential reality evoked during the therapeutic setting in a concrete and visible form.
Qui è proposto il percorso metodologico della 3D therapy con la fase A, la fase BX, la fase CX, fase D e fase E.
The methodological path of the 3D therapy is made up of 5 phases, which are the phase A, the phase BX, the phase CX, the phase D, and phase E. In the next slides, we are going to analyze these 5 phases.
La presentazione di questo lavoro verte su 12 soggetti di età e sesso diverso che sono presenti nella tavola B, con diverse problematiche psicopatologiche, ansia generalizzata, depressione, attacco panico, problemi di relazione d'attaccamento, fobie, lutto, PTSD, disturbi alimentari. L'obiettivo del lavoro è quello di esporre i soggetti all'oggetto 3D, osservare il loro comportamento nei primi 10 minuti, fase CX, e nell'esposizione prolungata, fase D ed E. e in più descrivere la sequenzialità comportamentale e i processi sottostanti le 3 fasi. La procedura è in questi termini: si sono selezionati dei comportamenti, tavola A, con la rilevazione dei comportamenti nella tavola B, con un'evidenza poi sequenziale fotografica, tavola C. I 2 momenti di osservazione comportamentale sono di 10 minuti nella fase CX, quando viene esposto l'oggetto, e i successivi 10 minuti nella fase D.
This work has studied 12 subjects of varying ages and genders with diverse psychological issues, including generalized anxiety, depression, panic attacks, relationship and attachment problems, phobias, grief, PTSD, and eating disorders. The objectives are: expose subjects to the 3D object, observe the behavior during the initial 10 minutes and during a prolonged exposure, and describe the behavioral sequence and underlying processes across the 3 phases. The procedure is to select target behaviors, record them using behavioral grids, and provide sequential photographic evidence of the exposure process. To divide the behavioral observation into 2 moments, during the first 10 minutes of exposure and beyond 10 minutes of exposure to the 3D object.
Qui inizia la selezione delle rilevazioni con la tavola A, dove vi sono collocati l'osservazione sugli occhi, sulle mani, sulla bocca e le verbalizzazioni e suoni. Per quanto riguarda gli occhi, abbiamo quindi la direzione dello sguardo, la fissazione dell'oggetto, la dilatazione della pupilla, l'esplorazione dell'oggetto, il restringimento delle pupille, oppure il non guardare l'oggetto. Per le mani, toccare l'oggetto, premere con il dito, prendere l'oggetto, spostare l'oggetto, non toccare l'oggetto. La bocca, sorriso, apertura, chiusura, verbalizzazione dei suoni, qualsiasi espressione, nessuna espressione.
In the survey, we have the target behaviors, and what we analyze is the eyes, the hands, the mouth, and the sounds of the subjects. For the eyes, we can detect if the gaze, where the gaze is directed, if the subject stares at the object, if the pupils are dilated, if the subject explores the object, or he doesn't look at the object at all. For the hands, we can detect if there is if the subject touches the object, pushes it, takes it, moves it, or doesn't touch it at all. For the mouth, we can detect if the subject smiles, or if there is an openness or rejection. And for the sounds, if there is no sound at all, there is no reaction at all.
Questa è la tavola B, dove sono stati messi in rilievo in una griglia tutti i comportamenti appena elencati.
Okay, this chart, which is the chart B, sums up all the behaviors which have been surveyed as a response to the exposure to the 3D object.
Qui sono esposte le foto in sequenza comportamentale del processo fisiologico presentato da parte di tutti i soggetti alla presentazione dell'oggetto 3D.
And these behavioral sequences, which are summed up in the chart C, and during the exposure of the subject to the object, which is phase CX, a physiological and dynamic processing is activated in the subject, which is easily perceivable on the face of the subject and evolves into a manipulative action on the 3D object. We have the exploration, which is the phase D, which is accompanied by manual, visual, and verbal coordination, and the exploration of the phase E, which leads to a reparative solution and emotional stability in the subject.
Sezione delle tavole che vanno dal grafico all'oggetto 3D.
So from the diagram to the 3D object, this is a presentation of the symbolic, graphic, and object-related references for each subject. Here we have some images of the 3D objects which have been realized starting from a drawing to the realization of a 3D object. The drawing has been made by the subjects. These are some of the examples of this work.
Sezione discussione. Nella fase iniziale dell'esposizione all'oggetto 3D, quindi fase CX, nei primi 10 minuti si sono osservati nei soggetti presi in esame una serie di manifestazioni comportamentali costanti e congruenti, con un iniziale shock di stupore e sorpresa e un avvio del processo esplorativo sull'oggetto 3D con un processo dinamico di forte impatto emotivo cognitivo visibile dall'eccitazione oculare, con una direzione dello sguardo, fissazione e focalizzazione dell'oggetto 3D, un'attenzione e concentrazione.
In the initial exposure to the 3D object, which is called CX phase, during the first 10 minutes, the subjects exhibit consistent and congruent behavioral manifestations, such as initial shock or surprise. The beginning exploratory behavior toward the 3D object, characterized by dynamic processes with strong emotional cognitive impacts, visible in ocular excitation, high direction, fixation and focus on the 3D object, attention and concentration, and an immediate manipulation of the object by some of the subjects.
Nei 10 minuti di esposizione si è visto quindi una identificazione rapida dell'oggetto e quindi la non pericolosità all'esposizione della situazione stimolo, dove vi è un processo automatico e non cosciente. Questa situazione di non pericolosità bypassa l'amigdala e ciò presuppone la disattivazione del sistema difensivo ed il coinvolgimento delle aree prefrontali.
During this 10 minutes of exposure, the subjects quickly identify the non-threatening nature of the stimulus through an automatic and unconscious process bypassing the amygdala and leading to the deactivation of the defensive system and the activation of prefrontal areas.
L'attivazione delle regioni, quindi con l'identificazione dello stimolo visivo e spaziale, cioè l'attivazione occipito-temporale ed occipito-parietale. L'attivazione della corteccia prefrontale mediale, dove viene stimato e valutato gli aspetti emotivi rispecchiati dall'oggetto 3D, offrendo quindi un comportamento più flessibile ed empatico e coinvolgendo il soggetto in una relazione e comunicazione con l'oggetto 3D e con se stesso.
The activation of the medial prefrontal cortex assesses and evaluates the emotional aspects reflected by the 3D object, provides a more flexible and empathic behavioral response, and facilitates the subject's involvement in the relationship and communication with the 3D object and with themselves.
Nella fase successiva, l'esposizione prolungata all'oggetto 3D, quindi fase D, si osserva una persistenza dello sguardo sull'oggetto 3D che consente un ulteriore sviluppo del processo fisiologico, un'attenzione focalizzata e concentrata sullo stimolo, un'attivazione dell'esplorazione oculo-manuale, tavola 3, e una costante esposizione emotiva che comporta un processo di scambio e confluenza emotiva con l'oggetto 3D, attivando un contatto pieno con l'oggetto.
The prolonged exposure to the 3D object, which is phase D, leads that during the next 10 minutes of exposure, the subjects maintain the focus on the 3D object, further developing physiological processes into sustained attention and concentration on the stimulus, activation of eye manual exploration, table 3, and continued emotional exposure, leading to a process of emotional exchange and convergence with the 3D object, which is called full contact.
Quindi attivando in questo caso una funzione, le funzioni esecutive superiori, quindi non solo l'attenzione, flessibilità cognitiva e inibizione, ma la contemplazione dell'oggetto, la sua osservazione, la riflessione e la metacomprensione.
The activation of the dorsal prefrontal cortex engages higher executive functions, which are attention, cognitive flexibility and inhibition, reflection and meta-comprehension, localized in prefrontal areas.
Attivando quindi un processo di desensibilizzazione e confronto con un processo sempre più esplorativo e discriminativo che conduce alla presa di consapevolezza degli elementi percettivi, emotivo-cognitivi riflessi dall'oggetto 3D, a tal punto da recuperare la memoria episodica processuale con una confrontazione e un ascolto interiore, sino ad un'autoregolamentazione emotiva.
In a synergic manner, an active exploratory and discriminative process develops with coordination of one's manual skills on the 3D object, leading to awareness of the perceptual, emotional, cognitive elements reflected by the 3D object. This is followed by the confrontation offered by inner listening and the retrieval of episodic processual memory, along with emotional self-regulation.
Qui, oltre i 10 minuti, il processo continua in una processualità integrativa ad esplorare e ad interagire con l'oggetto 3D, manifestando un comportamento di ricerca e di scambio, pianificazione sequenziale delle azioni finalizzate, scoperta, significazione degli elementi riflessivi pertinenti alla vita del soggetto e mentalizzazione, e conduzione alla cura del proprio sé.
Behind the 10 minutes, the process will continue with an integrative process of exploring and interacting with the 3D object, showing the following: search and exchange behavior, sequential planning of purposeful actions, discovery and meaning-making of reflective elements relevant to the subject's life and mentalization, guidance toward self-care.
La terza fase, il perdurare dell'esposizione, vediamo che i soggetti raggiungono pian piano delle soluzioni dinamiche attivate materialmente dall'oggetto 3D, che offre affondance e rispecchiamento delle esperienze emotive ed empatiche che consentono una flessibilità mentale. Tutto ciò evidenzia che la realtà oggettuale consente al soggetto di meta-riflettere e meta-comprendere.
During the continued exposure and the sustained exploratory manipulative process, the subjects reach dynamic solutions triggered by the material properties of the 3D object. This provides affordance and mirroring of emotional and empathic experiences, fostering mental flexibility. The material nature of the object facilitates meta-reflection and meta-comprehension.
Il processo di base porta piano piano il processo di mentalizzazione è accompagnato quindi da una ricerca sulla verbalizzazione e una trasformazione lenta della cognizione negativa, sino ad una flessibilità mentale e una riparazione correttiva adeguata sino al raggiungimento della stabilità emotiva, cognitiva e comportamentale.
In phase E, the subjects initiate a mentalization process accompanied by rich verbalization, transforming underlying negative cognitions. This enables greater mental flexibility, corrective repair, and emotional, cognitive, and behavioral stability.
I meccanismi sottostanti sono legati squisitamente ai neuroni specchio, e infatti l'oggetto 3D attiva i neuroni specchio che rispecchiano l'emozione disfunzionale riprodotta a livello oggettivo e fa risuonare affettivamente, producendo una rappresentazione motoria interna che consente un ulteriore salto qualitativo nel processo della comprensione cognitiva e della compassione empatica. Infatti, Gallese sostiene che la sua emozione è ricostruita dall'oggetto, quindi esperita e perciò compresa direttamente attraverso la simulazione incarnata che produce uno stato corporeo condiviso dall'osservatore.
The 3D object activates mirror neurons, which reflect the reproduced dysfunctional emotion, producing an internal motor representation. This enables a qualitative leap in cognitive understanding and empathetic compassion. Gallese points that their emotion is reconstructed, experienced, and thus directly understood through the embodied simulation, which creates a shared bodily state between the observer and the subject.
I neuroni specchio del soggetto rispecchiano ciò che avviene nella mente del terapeuta osservato, in questo caso dell'oggetto, come se fosse proprio il soggetto a compiere l'azione stessa, generando una rappresentazione interna dell'atto osservato, codificandolo in termini motori. Così la concretezza dell'oggetto 3D riflette ed attiva la simulazione incarnata nei 12 soggetti, offrendo una immediata percezione visiva della disfunzione emotiva e cognitiva ed avvia il processamento psicofisiologico, percettivo, cognitivo, emotivo, riparativo, utile in ambito riabilitativo nella prima fase procedurale e in ambito psicoterapico per tutto l'iter metodologico della 3D therapy.
The mirror neurons of the subject reflect what occurs in the mind of the observed therapist, as if the subject were performing the action itself, generating an internal representation of the observed act, encoding it in motor terms. The concreteness of the 3D object reflects and activates the embodied simulation in the 12 subjects, offering an immediate visual perception of emotional and cognitive dysfunction and initiating the psychophysiological processing. Useful in the rehabilitative field during the initial procedural phase, and in the psychotherapeutic field throughout the entire methodological process of the 3D therapy.
Così c'è l'esposizione diretta all'oggetto 3D che comporta un'integrazione dei processamenti bottom-up e top-down che vanno dall'orientamento all'eccitazione oculare e attenzionale con un'esplorazione manuale e verbale, una rapida identificazione dell'oggetto come non pericoloso, che genera quindi una desensibilizzazione emotiva e un comportamento di avvicinamento emotivo all'oggetto 3D, un processo di narrativa del proprio sé con l'autoesplorazione e autoconsapevolezza, sino ad una attivazione dell'affondance dell'oggetto 3D che offre il rispecchiamento delle esperienze emotive, empatiche, sino ad una mentalizzazione e flessibilità mentale e riparazione correttiva.
The direct exposure to the 3D object leads to the following: from orientation to heightened eye and attention stimulation on the 3D object, accompanied by a rich manual and verbal exploration, the phase CX. A rapid identification of the 3D object, an emotionally non-dangerous object that generates emotional desensitization and an emotional approach behavior toward the 3D object with the deactivation of the defensive system, which is the phase D. The process of narrating the self involves self-exploration and self-awareness of emotions and beliefs through the confrontation of experiences, which is the phase D. The manipulative strategy activated by the thinking of the 3D object offers a reflection of emotional and empathic experiences, leading the subject to mentalization and mental flexibility, bringing about a corrective repair, the phase E, to the 3D object and its history, from self-regulation to emotional stability, with the cognitive evolution that is more functional and adaptive to the subject.
Concludendo, i soggetti giungono ad una immediata consapevolezza delle cause che bloccano il loro comportamento e attraverso la confrontazione, mentalizzazione, giungono ad una maggiore flessibilità mentale sino ad un'efficace soluzione del loro problema ed una stabilità emotiva cognitiva. E riconoscono che il grado di consapevolezza immediata è coadiuvata dalla riflessione dell'oggetto 3D accompagnata empaticamente dal terapeuta.
Our conclusion is that the subjects gain an immediate awareness of the causes that block their behavior, and through confrontation and mentalization, they achieve greater mental flexibility, leading to an effective solution to their problem and emotional cognitive stability. And that they recognize that the degree of immediate awareness is supported by the reflection of the 3D object, empathically guided by their therapist.
La bibliografia. Grazie per l'ascolto.
Thank you. Thank you to all of you. If you have any.
Hello, everyone. I'm Dr. Christine Rio Business Nadala, a psychiatrist with training in psychoanalysis. But today, I'm here not only in my professional capacity, I'm here as a sibling and as a caregiver. This talk is intensely personal, rooted in a journey that has profoundly shaped my life, and I believe resonates deeply with those in medical and mental health fields. This talk is based on my article, Beyond the Unknown, which delves into the transformative journey of caregiving, especially caregiving within Southeast Asian context, where family and community bonds are central to well-being. In this context, caregiving isn't just an act, it's a shared responsibility, a part of who we are. Introduction. Entering uncharted territory. Caregiving through rare cancer is a deeply unfamiliar landscape. For my family, this journey began with my youngest sibling B-Boy, who was diagnosed with a rare type of cancer known as monochromatic synovial sarcoma. This diagnosis opened the door to an intense and often daunting journey, one that demanded not just medical expertise, but also resilience, vulnerability, and the courage to confront the unknown. Today, I'll walk you through 3 phases of this caregiving journey: diagnosis, treatment, and acceptance. Each phase presented distinct challenges and taught invaluable lessons that echo deeply with psychoanalytic perspectives and themes relevant to Southeast Asian culture. Phase 1. Diagnosis, when life becomes precious. The initial diagnosis marked a time of profound vulnerability. As the only doctor in my family, I felt the dual responsibility of guiding my family through medical decisions while also being a source of emotional support for B-Boy. In Southeast Asia, caregiving is typically a family affair where roles are shared and emotional support is collective. This communal approach became our anchor, grounding us in faith, shared family strength, and the comfort of leaning on each other. During this period, I sought solace in mindfulness, prayer, and mentorship. It was an emotional upheaval, but it taught me that vulnerability is not weakness, it's a form of resilience. Vulnerability allows us to stay open to our loved ones' needs and create spaces of empathy and connection. From a psychoanalytic lens, I see this phase as an exercise in holding. Holding means creating an emotional space where our loved ones feel supported and secure, even as we struggle ourselves. For our family, this meant giving B-Boy a space where he could express his feelings and fears without having to shield us from his pain. This holding became a shared act of love, resilience, and ultimately strength. Phase 2. Treatment, embracing joy amid challenges. As B-Boy entered treatment, our journey became a series of adjustments and adaptations. His chemotherapy lasted nearly 2 years, a period marked by highs and lows, small victories, and challenging setbacks. During this phase, we learned the importance of celebrating life's small moments. Despite his treatment, B-Boy made the brave decision to marry, a choice that reminded all of us that beauty and joy can exist even amid great pain. This decision was not an act of denial, but a testament to resilience, a reminder that love and life continue. In psychoanalytic terms, this phase revealed the significance of finding meaning in suffering. As caregivers, we embrace the concept of the good enough caregiver. We did not need to be perfect. We only needed to be present. This idea showed us that imperfection is okay, as long as the intention and support are genuine. Family dynamics became complex as each member coped differently with the emotional toll. I found myself balancing control with surrender, learning to let go of the aspects beyond my reach. Relinquishing control, I realized, is an act of compassion. We were there for B-Boy not by micromanaging his care, but by offering unconditional love and acceptance. Phase 3. Acceptance, honoring autonomy and finding peace. As B-Boy's condition worsened, he made the courageous decision to forego further treatment, choosing instead to cherish the simple joys of each day. This shift was a humbling experience as my role as a caregiver transformed. No longer focused on preserving his life, my role became one of honoring his autonomy and supporting his decision. In psychoanalysis, we speak of the unconscious third. This concept refers to an invisible space shared between two people, which fosters empathy and mutual understanding. In B-Boy's final days, I felt this presence strongly. His choice to accept his fate forced me to confront my instinct to fix things, to make everything better. I came to realize that part of love, part of genuine caregiving, is learning to let go. Culturally, this phase highlighted a Southeast Asian belief in acceptance and surrender. It allowed me to move from being a caregiver focused on preserving B-Boy's life to someone who honored his journey as his own. This phase wasn't just about death. It was about a profound transformation in how I viewed life, autonomy, and acceptance. This journey taught me that acceptance isn't just passive, it's an active, evolving process. It required me to witness B-Boy's experience and allow it to shape my understanding of life and death. Grieving is a dynamic, non-linear experience. Often, caregivers feel an overwhelming need to control outcomes, to shape events according to what we believe will bring comfort. But caregiving, as I learned, is about surrendering that need for control, honoring the autonomy of our loved ones, and finding strength in respect. In Southeast Asia, our journey mirrored the region's deep-rooted respect for family roles and personal choices. Letting B-Boy make his own decisions, even the choices to decline further treatment, became a lesson in humility, respect, and honor. The grief we felt was not only individual, it was communal, shared, and deeply connected to our family's cultural values. In this way, grief was not something to overcome, but something to experience together as part of our family's ongoing growth. As caregivers, we often focused entirely on the needs of our loved ones that we neglect our own. In our journey, I came to understand the significance of self-care, discovering that taking time for solitude or maintaining a journal was not a selfish act, but a necessary one. Self-care became a radiant force in our lives, a grounding practice that helped me remain present and resilient. Within Southeast Asian culture, balancing one's well-being with others' needs is often seen as a cultural duty. Yet, I found that the caregiver's emotional state directly influences the patient's experience. Psychoanalytically, this aligns with the concept of transference, the idea that emotions, whether spoken or not, are felt and carried by those we care for. In caregiving, our emotional presence is a form of energy, an influence that impacts our loved one's sense of peace and comfort. Conclusion: a journey of love and transformation. In closing, I encourage all caregivers to see their journey as an opportunity for transformation. Southeast Asian caregiving is about community, resilience, and shared love. By honoring the sick, embracing vulnerability, and prioritizing self-care, we elevate our caregiving. This journey, in all its complexities, is a testament to the resilience, compassion, and enduring strength of human spirit. Thank you for allowing me to share this deeply personal journey with you. Caregiving in any culture is a sacred role. By nurturing our loved ones, we find ourselves transformed and discover our shared humanity in the process. Salamat and mabuhay.